All right, we're well above the quorum now. John, are we live?
Yep.
All right. Well, good morning, everyone. Thank you for being here. We have a full agenda. I know you're really busy, and so again, appreciate your time. But a lot of really important things related to the consortium are moving forward. We're going to spend some time talking about the legislative session and then get an update related to the variety of the consortium initiatives. Again, I think a lot of good news and a lot of progress over the last month. So with that, let me go ahead and officially take roll. And so again, when I call your name, if you just recognize that by saying aye or present, that would be great. Dr. Goodman?
Present.
Dr. Williams?
Present.
Dr. Liberzon? Dr. Harper from A&M?
Present.
From Texas Tech, Sarah Wakefield?
Here.
And Dr. Trevino?
Here.
And from Texas Tech, El Paso, Dr. Thompson?
Present.
And Dr. Martin?
Present.
Thank you. And from University of North Texas Health Science Center, Dr. Podolwitz?
Present.
And Dr. Chesay?
Good morning, present.
Good morning. And from Dell Medical School, UT Austin, Dr. Nemiroff?
Present.
And Dr. Strakowski?
Present.
Very good. From MD Anderson, Dr. Tan and Dr. Robert. From UTMB, Dr. Wagner
Present.
and Dr. Vo. Dr. Vo, I forgot, Dr. Vo contacted me. He's in transit right now and will not be able to join us. From UT Health Science Center, Houston, Dr. Suarez.
Here.
Very good. And Dr. Newland.
Here.
Okay. From UT Health Science Center, San Antonio, Dr. Plitzka.
I'm here.
Very good. And Dr. Blader. Okay. From UTRGV, Dr. Escamilla. Michael. And Mr. Patriarca.
Present.
Very good. From UT Health Science Center, Tyler, Dr. Bryant.
I'm here.
Very good. And Brittany Nichols.
Here.
Very good. From UT Southwestern, Dr. Taminga.
Present.
Very good. And Dr. Ibrahim. From the Texas Health and Human Services Commission, Mike Maples.
Here.
Very good. And Sonia Gaines.
Here.
Very good. From the Texas Higher Education Coordinating Board, Dr. Silverman. From the Hogg Foundation, Dr. Martinez.
Good morning, David.
Good morning. From the Meadows Mental Health Policy Institute, Dr. Keller.
Present.
Very good. From Texas Council for Community Centers, Danette Castle.
Here.
Good. From Children's Health, Ms. Wesley.
Present.
Okay. And from Scott and White Health, Central Texas, Dr. Borges.
Here.
Very good. I'll have my team count it up, but we are well over a quorum. And so again, appreciate everyone being here today and look forward to the discussion that we're going to have. First order of business is the minutes from the last meeting. If everyone could take a look at that. Luann sent it out this morning, but if you could take a quick look.
Move to approve.
I have a motion to approve from Dr. Polowitz.
Second.
Second from Dr. Taminga. Any further discussion? Hearing none, all in favor of passing the minutes from the last meeting signify by saying aye.
Aye.
Opposed, nay. Any abstain? So by voice vote, we have unanimous approval of the minutes. So now let's go to item 3, and we're going to start off with an update on the 87th Texas Legislative Session for items that are pertinent related to children's mental health and our consortium. And Sean, I think we start off with you.
Hey, good morning. Thank y'all. So it's still pretty early in the legislative session. A lot of sort of organizing activities. In fact, right now, Senate Finance is meeting for their first organizational hearing. So there's not a whole lot of updates to some of the information you may have already been provided, but I think most pertinent for this group, the information we sent out a couple weeks ago when the budgets were introduced, and just sort of to summarize that, the Senate version of the introduced budget has full funding for the consortium to what has been estimated to be the fully operational level of funding that you guys are ramping up to right now. So that's a great sign. They've revised the rider as well to kind of get rid of some of the transitional stuff in the beginning, the plan and other steps. So that's probably ideal and really what would help the consortium the most continue into the future. Now, the House version did not include that increased funding, and it did not change the rider other than just updating some dates. But I wouldn't take too much of a negative view of that. It's sort of to be expected. The Senate really took the lead on prioritizing the consortium in this issue. So one would guess that the Senate would continue to take the lead on the funding item. And I wouldn't take anything away from the House not having it at this point. In fact, at the end of last week, we got some other good news for the consortium in that the budget of the governor included the mental health consortium as one of his priorities. The governor doesn't directly play a role in writing the budget, but it's great to have his support, obviously, for anything. And on a minimum, he's not going to veto the funding. But it's helpful as the negotiations go with the House, as they see that he is, marked down his support for this initiative. It'll help the members over there understand, how much support that it has. So it's all in all good signs. We'll continue to monitor. As I said, Senate Finance right now is just having their first organizational hearing. The higher ed agencies and institutions don't come up for another couple weeks, February 20th that week. So we'll see how it's discussed then, because the funding does go through the coordinating board's budget, of course, and we'll be ready at UT system level to speak and answer any questions that the membership has about that. There'll probably be another few weeks before the House really gets going on their budget hearings as well, but we'll be keeping an eye on that. Legislatively, for the consortium specifically, no bills have been filed that adjust the consortium statutes, and we haven't seen any references either in other legislation to sort of adding duties or pointing towards the consortium. So far, no movement on that. We'll continue to keep our eyes out, though, and keep you all updated if we see something. From a general sense, healthcare is front and center this session. I'm not going to get into too many specifics. I know Andy has a lot more information for you all here right after me, but obviously telehealth and mental health are going to be big priorities. So we'll continue to look as all these things develop. And I'm happy to answer any questions specifically about the budget as well.
And I probably need to apologize since we're having an opens meetings meeting, and many of us know Sean, but probably should have formally introduced Sean. So Sean Griffin is our Associate Vice Chancellor for Government Relations within the University of Texas system. So are there any questions for Sean? And maybe it'll be easier to answer questions as a whole after Andy talks. And so, again, if there's any specific ones for Sean, but we're going to have Sean hang on for the rest of the presentations related to the legislative session, and you can come back to him for any further questions. So Dr. Keller, why don't we go to you? And great. Again, I think, again, to comply with the Open Meetings Act, Dr. Keller is the CEO of the Meadows Mental Health Policy Institute. Dr. Keller.
Excellent. Thank you, Dr. Leakey. And Nagla, I think I have some slides just to show you all that we care enough to make slides for you. And so first we'll start out just with just echoing Sean's overview on the budget. I think that's right on. And I would just add on that point about the two budgets. with Dr. Bonin being chair now of House Appropriations, that's a good sign, because you may recall that he was the one who worked with Dr. Zerwas to help get Senate Bill 10 into Senate Bill 11 last session, and so was instrumental in the existence of the consortium. So I think we should be really optimistic, and there's, I think just this is, the good work we're doing, everybody I think is very positive of, and it's very natural, like Sean was saying, for things to be where they are now, for the Senate to take a lead. So if you can go to the next slide, Nagla. I would just say, the good news for us in terms of moving forward is just the tremendous difference in what the budget was thought to be. And many of you know this, but I just want to make sure everybody, looks at this. I mean, we were expecting, as of last July, almost $5 billion shortfall. And most of us thought that was going to be worse. Like, we expected as the fall to come for things to be worse. And, instead we ended up in January 2021 with, less than $1 billion shortfall. And, we see Congress at the national level, moving forward with relief to states that will help us. And so I think just, from that perspective, we're certainly going into this budget session with a lot less bad situation. Of course, we're Texans, we're sober, we don't want to spend extra money, we're very frugal and careful, but it just means there's less pressure, and it's less of a bad thing. So next slide real quick. Sean, I thought, did a great overview of where the consortium's dollars are, but I think it's also important to look at the larger ecosystem of mental health support. So the 1115 waiver being extended through 2030, with the direct payments on mental health and other components in there, and for the hospitals, is in some ways very, very good. I mean, it's good for us in terms of the continuity of mental health services. I think some people see it as concerning because it reduces the likelihood of other healthcare reforms that would help the other healthcare needs of the people we serve. But I think for the mental health and substance use disorder components and the hospital components, it's very stabilizing and very good that we have that in there. But people with mental illness mostly die from the below the neck needs. So there are some major gaps still. And I think overall too, a lot of the grant programs, if you look in there, they're fully funded. The Justice Involved Veterans Program, Veterans Family Alliance, the Community Mental Health Grants, the HB 13 grants, the Healthy Communities Homeless Grants, all of those are fully funded in both budgets, which is really good. And so I think just keeping that in mind well. So those are all early wins, and it means mental health is going to have a net increase if things progress as they are. And that's what we need, given all the harms from COVID that we're seeing that are increasing mental health needs. Next slide, please. I do think Sean alluded to this or mentioned this, but securing the gains through telehealth, that is critical. And I would really encourage folks to look at HB 974 and SB 412. And also remember, we need all the details. It's not enough to just have telehealth go forward. We need audio only in there. Audio only is critical for continuing to have the gains. Broadband's awesome. This is lovely to be able to see all your beautiful faces. But you could probably no one's actually looking at my face right now. At least I hope you're not. You're looking at the slides. So you're hearing me fine using audio only. Audio only is a powerful thing, and most people have phones. So please don't just have your people support telehealth. Make sure they look at the audio only piece. And if you have questions about it, circle back with us or others, and we can help you understand both the efficacy of audio only, as well as its importance for reaching underserved folks, and not just in rural areas, in urban areas where folks do not have access to broadband. So that's a really important one. Next slide, please. State hospital redesigns going forward, and that's really important in terms of state. You all are the key partners there, and the Houston, and then also we're going to be seeing operational costs coming in, which is really exciting, coming online. So that's the parents, that's the aging children that are going to be going into adulthood. So it's really important to have all this going forward, and it's important that we all keep mindful of this as well, because if we lose here, it's going to certainly undermine our efforts more broadly. Next slide, please. And then this is one that's also really important that we did not expect to see traction on, but I think the brighter budget picture, as well as I think the insights people have about how if we're going to get ahead of suicide and overdose deaths, we have to intervene in primary care, is to turn on the collaborative codes for Medicaid. Collaborative care are codes that allow behavioral care to be reimbursed in the primary care office. And most commercial payers cover this. Medicare has covered it since 2017. And the only health plan that doesn't cover it right now is Medicaid. And that's a big problem for the consortium, because most children in poverty in Texas have Medicaid. And so turning on the Medicaid codes is such a good thing. We're going to try to get them turned on for everybody, the adults too, because they will be super helpful for adults. But one problem is it's a little bit more expensive for adults. So we're trying to point out that the expense of this will be phased in over years. The savings will be 6 to 1 once it's fully implemented. So over time, it pays off. But of course, the Medicaid, when they're doing their cost projections, they don't look at those future savings. They just look at the impact on the current budget. So the impact on the current budget will be a slight increase. We're trying to help them understand that it takes years for this to phase in. So, Baylor Scott and White is partway into doing this across hundreds of clinics, and it's probably going to take them 5 or 6 years to fully get through all their clinics, and other health systems are further behind. I think some of our children's hospital partners will be able to run with this a little more quickly, but that's not much cost for the children overall. And we see huge cost savings there. So if we actually want to do more to robustly support our primary care providers, we really need you to hone in on this one. And all of the health plans, all of the hospitals, the pediatricians are all in favor of this. And we expect to see a bill hopefully this week come out on it. So we'd like people to watch for that and really look to support this. And if you have questions about it, talk to us, because we're happy to talk to you about it. But this is one we think will really help the people we're helping through the consortium on the children's side. And I believe that's my last slide, unless Nagla, is there another one? Yeah, that's the last slide. So no need to look at our logos. We can go back and to look at everybody's pretty faces and less pretty faces like my own. And if there's questions, and Sean, also, if I misstated anything or if you want to clarify anything, please jump in.
Andy, the only thing that I would potentially add to that is, Sean brought up the governor's budget and would note that 2 specific items that are important to this consortium. One, the support of the consortium itself, but there's also a specific paragraph related to the state mental health hospitals and the governor's support to finish the construction for San Antonio and Austin State Hospital.
Thanks for adding that, David. I would also add too that we also are not done with our state hospitals, as you know, and planning dollars for Dallas, for West Texas that need to move forward, being able to have synergy with, JPS's very far-ranging rebuild of its facilities, the potential for synergy there. So, hopefully we aren't just going to continue with the promises made last session, but also continue to look at the needs of the rest of the state, which I know, David, I primarily blame you for putting together the plan that is eventually going to get us to have a contemporary hospital system in this state. So thanks for your leadership on that. And we do need folks to continue to look at North Texas and West Texas as these needs are prioritized.
Well, thanks. A lot of people have been involved in this, obviously, but it's really important that we have a modern system to care for those that are unfortunately hospitalized. Mike, anything? I saw you turn on your camera. Anything you would like to add to that conversation?
No, Dr. Keller stole my thunder about, that yes, the free biennial plan is kind of coming to fruition, but we do still have other projects that we've been talking about. Certainly the Dallas is the only urban city in the state that doesn't have a state hospital presence. And so that's been a big focus. Had talks and conversations with Dr. Tominga over the last several years and her leadership about partnering there. And also Dr. Trevino and I had a conversation about Texas Tech potential partnership in West Texas. Very, very important that those next steps. I did want to add too that on Andy's slide about the operations cost, it does look like that San Antonio was already funded in the base bill. So that's a step forward to the operations of the new unit, 40-bed unit there in San Antonio. So that's one item that was funded in there. We still have to focus on finishing out the construction of Ash and Sash, and certainly the operational dollars for the Behavioral Science Center in Houston and the Kerrville beds, and certainly keeping the San Antonio beds. But all indications are stepping in the right direction. So we're very positive. Appreciate everybody's support over the many, many years. And certainly I agree with Dr. Keller, Dr. Lakey, it started with you and kind of those conversations many years ago. And hopefully we bring the free biennial plan to a successful close this biennial, but then keep looking to the future for the rest of the projects.
Very good. Any other questions? Sonia, I saw your light up. Anything you were going to say?
No, I thought Dr. Keller did a great job of presenting. I'm glad that Mike chimed in as well. No, I don't have any other comments.
All right, very good. All right, one note of business before we go further down the agenda. Dr. Ibrahim is here. Has joined us. Any other consortium members that have joined us since we did our roll call? If you could recognize yourself, that would be great. I think that's the only one. Okay. Hearing none, let's move to the next item on the agenda, and that is the consortium's communications and marketing. Daniel, are you there?
Yep, I'm here. Let me share my screen and I'll just run quickly through some updates. So I just wanted to show you, we had on the website, this bar at the top had been something different before. It had directed people specifically to COVID mental health resources. We adjusted that in light of some conversations at the last meeting. So it now has that first number, the 800 number, I think is the National Suicide Helpline. And then we're also directing people for more Texas-specific resources to mental health, texas.org. So I just wanted to show you that. We added a page, and this was a kind of pragmatic thing, but it opens up a little bit of possibilities. We're looking for some web development to help with the next iteration of the website. So we needed somewhere to post something. So we created a careers page, but this is open if other people have consortium specific positions they'd like to list. I don't necessarily know how much traffic it's going to get, but you can get in touch with me if you have something that seems appropriate for that page. I wanted to show you that. We have, working with Dr. Williams and her COSH team, we've sent out newsletter. They have a contract with Texas Pediatric Society to send out a newsletter, some other things, but a newsletter to their membership once a month for the next 6 months. So the first one went out in relatively early January, had a letter from their president of TPS, directed people to this intro video about CPAN that Dr. Williams and Dr. Tran are in, and then also directed people to the map on how to access CPAN depending on your region and affiliated institution. The next one is scheduled to go out this week, and it has a letter from actually the past president of TPS. It has a listing of upcoming continuing education webinars. If anybody has any in addition to that, it's probably not too late for the next day or two to add some stuff to that. And we're also going to add a page to the website with these opportunities. It directs people to the new resources pages on the website. And then also we kind of reiterated this just because it seems important people know how to use the switchboard. We've added a few things to Canva in the last month or two. And I'll show you, so this is just the general Canva page where you can see what's up, but I'll show you two of them in particular. This is one that's very much about for providers, how to access CPAN. You can see this has the Delmed. I think this is adapted from something they do. It has their logo, but this can be swapped in for your institutional logo. And also this, it sort of gives specific instructions if you're in the Delmed catchment area, but you can change these numbers and this text to reflect your institution. And this is kind of a different version of the same thing. It has the whole map with the switchboard instructions, and you can update the logo and you can add some text, just giving people specific instructions for their region. And then the last thing I was going to show you was just, this may have been mentioned in the previous meeting, but another one of our initiatives at UT System is the Texas Collaborative for Healthy Mothers and Babies, which is the state's perinatal quality collaborative. Our summit is coming up is that next week? Is coming up next week. No, it's this week. I'm sorry. A little overwhelmed with the details on that. So later this week, registration is closed, but give me a ring if you decide you want to go. There's some overlap with the consortium. Luann is moderating a presentation from Nancy Byatt, who is involved in Massachusetts McPAP for Moms program. There's that session. There's also at least one session on postpartum mental illness. There may be two. So if you're interested in that, I just wanted to let people know That's coming up at the end of this week, and reach out to me if you're interested, but registration is closed and you want to find your way in. And I think that is all I have for now, but happy to answer any questions that anybody has.
Very good. Any questions or any feedback for Daniel?
Daniel, thank you for making those templates. Those are going to be very, very useful for us in our local advertisements. Nice job. Thank you.
All right. Well, thank you, Daniel. Yeah, good work. I also want to recognize Dr. Joe Blader. He has joined us. And again, if there's anybody else that hasn't recognized themselves, please unmute yourself and let us know. Otherwise, we will move to the next agenda item. Hearing none, Dr. Lopez, Molly Lopez, let's have the update related to program evaluation and the work that you're doing with your team.
Hey everyone. Really, we just wanted to offer a thanks for the feedback that we've been getting from folks on various tools and processes we're putting in place. We appreciate those coming in so we can adjust as we get these kind of settled. Other than that, we don't have any updates unless folks have questions for us.
Any questions for Dr. Lopez? Seeing none, thank you very much. Let's move forward then to the research initiative. This month we will have the update from Dr. Trivedi, but Dr. Tuminga, anything you want to say before we move into Dr. Trivedi's update?
No, I'm pleased with the research consortium. They're moving ahead and getting all of the health-related institutions into the research networks, into both of the networks, and it just is extremely promising for the future of this kind of research in Texas. Both Charlie Nemiroff and Madhukar Trivedi are doing it, and their teams are doing a terrific job. As you remember, Dr. Nemiroff presented his childhood trauma, the picture of his team last time, and Madhukar will do the same thing this time.
All right, Dr. Trivedi, I'm going to turn over the platform to you.
Thank you. Thank you very much. Thank you, Carol and Dr. Leakey, and thank you, Charlie, for doing this last time. So I'm going to follow a similar model. I think both the networks are going very much similar in their trajectory, and I think it is very exciting to see that all the 12 nodes are now certified, trained, and ready to go. And I'll show you the data we are collecting so far. But I think the two things for the group to hear about. One is we are progressing. Everything is moving in the direction of getting all the 12 nodes stood up for research readiness, and they are all recruiting. And the other very little, but a very important example of the richness of this, and we just submitted a large PCORI grant to study suicide prevention, and was a lot of work, but I think the most heartening thing was all the nodes really participated very actively. I can't thank enough for a lot of people, Dr. Wakefield, Dr. Storch, Dr. Blader, Dr. Escamilla, all of them, and Israel. That was amazing. So I'll come to that at the end, but I think we are now primed to do, and I'll give you the numbers where we are getting. We have a lot of network and hub activities happening, weekly hub meetings, regular committee meetings. We have monthly network meetings. We, for example, had about 10 meetings already, of which average attendance is 50 members. And we do discuss individual node updates, etc. There is also additional activities going on, like weekly coordinator and assessor meetings. We've had 22 of those, average attendance there being 30 members. We have IRB regulations, recruitment planning, a lot of problem solving, and really moving this into truly a one network. I think that is really something people around the country are beginning to notice, and Charlie can add, Dr. Nemiroff can add more, but I think other people around the country, in the research world, are really beginning to pay attention and notice this. We have monthly assessor consultation meetings in order to ensure at the end of this, even already now, but at the end of this, we will have very highly trained, highly certified, research-ready, highly qualified people all across the network. We currently have 35 assessors certified, 55 research operations trained. We are actually, one of the things about the depression network we really focused a lot, and thanks again to Dr. Wakefield and Dr. Storch, we've actually created this really practical measurement-based care, collaborative care model training. So Dr. Keller, I think that as much power as we can give you support for Medicaid to start really recognizing collaborative care would be fantastic, because these patients that are being treated across this, where everybody is now trained and certified on measurement-based care and collaborative care, will actually be able to implement it. Because one of the things people don't realize that stops from good quality of care in depression is reimbursement structure, and I think that will really help. We can talk more about it, and Andy can obviously expand much more about it. So let me talk about the network. This is where we are. We have, and this is as of last week, so now we have 209 people who have been consented, and you can see the numbers. I think the numbers of people getting recruited at each of the nodes are rapidly accelerating. There is usually a 2 to 4 week or 6 week runway period when once people start, the net node gets going for them to really jump up. So I think that don't let the numbers in the lower half fool us. They will really pick up. I think once the machine is rolling, you can see from UTMB, UT Southwestern, and JPS, the numbers will really rapidly increase. So we have really and this is a group of patients whose care has two fundamental advantages for us in terms of thinking about this. Three. One is this is diverse. So you can see all the way from rural areas with Lubbock as well as urban areas, more minority representations. You'll see that as we come along. But so that's one thing. The second thing I think is that we are longitudinally following this so that we can get the understanding of the variability and outcomes. And the third is we are actually focusing on improving the quality of care that not many real world, real practice projects like this have done. These are the active participants by node, and you can see the proportions coming from each. I think I am like Tyler is very close, and once they start enrolling, one of the things people don't realize is that this depression is a very common condition in the population, and we just have to figure out a way to connect the need with the delivery of real good quality of care. Total number of study visits that have been completed is close to 700. And in fact, we are now rapidly getting to 2 month, 4 month, and even more over the year. We'll have real longitudinal data that tells us exactly how Texan children are being identified, treated, and what are the outcomes. And the predictive models will tell us which subgroups of different subgroups of depression require more care than less care, and which regions and which underserved populations will require more care, more support, etc., so that it can help the legislature actually very articulately devise mechanisms to support and deliver infrastructure. These are the population we have now. Majority of, as was planned and hoped for, is 12 to 17-year-olds. But an interesting real distribution for this is on the two extremes, on the two ends of this distribution we were going after, we have 10 to 14% of the population. Again, thanks to Israel for pushing us on this. 11 to 20-year-olds, more towards the 18 to 20-year-olds, this should be 18 to 20, this number. 18 to 20-year-olds, we're getting 14%. I think that is wonderful because there's nothing magical about somebody turning 18 and now there's a different population. The contingencies required to improve the care are actually similar. Majority are female, not surprisingly. Unfortunately, as we all know, depression and suicide is very similar for boys and girls until they hit puberty. And then as soon as puberty hits, girls and women end up unfortunately having double the rate of depression and suicide attempts. And I think that is a real conundrum for us, and we need to be paying full attention, because as this moves on into the adulthood, its impact on families is even more pronounced, and we need to be doing more. We are getting a distribution of gender identity also as we measure this, and more will be noticed as we get to larger numbers. We are getting a very wide distribution of race and ethnicity. As you can see, about 12% African American distribution, 5% Asian, very small numbers in terms of Native Americans and Pacific Islanders, but still a fairly wide distribution. As some of our other nodes start enrolling more, we will see this distribution even become much more represented. This is already getting to the representativeness of the population in Texas. So we are very proud of the fact that we're already one of the things, as you know, with all of these research efforts in the country and even in Texas, has been that minority representation is these research. We are hearing about this in COVID, et cetera. The minority participation has been always lagging, and we are actually doing better than that. And thanks again to all the nodes for being very mindful of this. And we've had a lot of stakeholder advice on that. Dr. Martinez has been one of the big champions on, at least from the executive committee, but all the other nodes are doing a fantastic job. We are getting about 43% of Hispanic representation in the population we are studying. A little bit about the population, just to give you a sense, this is a very severe population illness. So this is not just easy to treat population. As you can see here, for example, the distribution of the severity of symptoms at the time of presentation, you can see close to 17% of the population is very, very severe. Significant number is moderate to moderately severe, 25%. So this is again not this is a population that is in need of care. And these population also has significant anxiety, as again you see 33% of these patients with depression have profound amount of anxiety symptoms that would require additional care, and just throwing a traditional antidepressant treatment has not been enough in the past. This is a severity of this illness is really becoming even more stark, as you can see here. 26% of the population we have recruited have reported significant enough suicidal ideation and thoughts that somebody will need to do something more than just the antidepressant treatment. 26% of these young people report one of the three answers. I have been having thoughts of killing myself. I have thoughts about how I might kill myself, and I have a plan to kill myself. This is not something that can be defined as mild or moderate. All the other components of the presentation of the illness are also what we are actually looking at through all this. As one of our collaborators said, the measurements are quite extensive, and one of them was joking about it, is that there is enough ornaments on this Christmas tree that it is lighting up fully. So we are measuring suicide propensity, because one of the things that has been a big problem in suicide work is people measure how suicidal you are when you present. That's like identifying how bad the disease is when somebody has stage 4 breast cancer. We need to be thinking about it much earlier. So we are actually assessing suicide propensity before people get suicidal. Same thing with irritability, insomnia, physical functioning. This is the more elaborate assessment of the severity of the presentation and the full range of symptoms through this rating instrument called Inventory of Depressive Symptoms that has been validated quite for a long time, developed by somebody here, one of our colleagues in the past, John Rush, and this rating instrument has really real value. Look at the primary diagnosis we are getting: major depressive disorder, not only that, but bipolar disorder, separation anxiety disorder, some population, as you can see here, which has major depression with psychotic features. This is, again, the most severe of the severe depressive disorder diagnosis. And most of these people have comorbid diagnosis. 50% of them actually have 3 or more additional diagnoses to depression. Again, amplifying the same theme that this is what we are getting is the more severe of the group of people, young people who have depression that are being recruited. Rightly so. This is the group we want to make the biggest impact on. So I think that 42% of them have recurrent illness. So by the time they are 14 and 17, they have already had 2 episodes. We have to be really, at another time discussion, we have to do this much better. We have to intervene and screen much earlier. We should be doing this in schools. We should not wait until the 17-year-old has a 2nd episode by the time they are 17. I mean, it just is not the way medical illnesses are treated. We should be making a difference in psychiatry. As you can see, 22% of these patients have had a past panic disorder. 10.4% of these young people have had experience with illicit substance use, and 4% have had an alcohol use disorder. You can see examples of other things: using anything to get high, days in the past year, or more drinks in a day. As you can see, the good news is you look at the median, it's all zeros or close to 0, very clearly suggesting it is not happening to everybody. There is a proportion, a subgroup that has exposure to these risk factors, including alcohol, marijuana, tobacco, etc. The age at onset is 10 years. Imagine the set of illnesses which begins at 10. We spend a lot of our work as a society on worrying about, and we should worry about Alzheimer's, etc. That doesn't start at 10. This is really, we are witnessing somebody's life really start having problems very early in life. 1.7% of the number of lifetime suicide attempts is 1.7 as a mean. We'll give you a little better distribution next time. So 49.5% of the people in the study have attempted suicide in the past. Again, same pattern. As Dr. Nemiroff pointed out, there is the good news that we are accomplishing through this, I think, in my view, is we are creating, quote unquote, 2 networks. And that is fantastic. And we are actually going to have having functioning networks. There is a lot of overlap. So you can see here, this is the group of patients that were identified for depression, recruited through there. But the range of traumatic experiences they've had in their life are very comparable and similar to what Dr. Nemiroff showed last time. And I think we'll be able to actually have a lot of cross-network assessment of our data and work on really trying to maximize how we can understand this much better. These are the worst ever traumatic events in these young people's lives that include kidnapping, mugging, separation, natural disasters. But natural disaster, while problematic, is not the driver for a lot of our patients who have depression. It's the other things that we have that are preventable. Animal attack, family violence, family verbal threats, family jail are all actually events in somebody's young person's life that if that happens, we should be intervening, as Dr. Nemiroff's group is really starting to consider. There is a lot of service utilization for this population, and that is why judicious understanding of who needs more resources and who needs less is going to become very much more interesting as we go forward. As you can see here, the range of things people are being exposed to in terms of services they have to be using. ED for emergency department for psychiatric evaluation. I think, in my humble opinion, as a psychiatrist and as an expert in depression, suicide, I wish we get to a society where that is not needed. Because what that tells you is that all other stops failed and now nothing has worked. That is why you're doing a psychiatric evaluation in the emergency department. It should be something that the signs and signals of that need would have occurred for many years before that, and we should be stopping that. These are the kinds of services. In the interest of time, I'm going to I think I've given you a good flavor of the nature of the population we are studying, and we can do more. We have a lot of quality assurance programming built into this. We do inter-rater reliability, and again, you saw that with Dr. Nemiroff and Newport also discussing last time. We have quality assurance plans for each of the nodes. We'll do individual selected node assessments and provide guidance, help, support. Increasingly, we are getting, this is becoming a team, and therefore we are not providing anything. We are really collaborating. We, as I mentioned earlier in the process, there was a PCORI is, all of you know probably, but those who don't, PCORI is a central peer-reviewed organization called Patient-Centered Outcomes Research Institute. And I know Octavio is very excited about this because it really requires us to be patient-centric in our research questions. We had submitted a competitive LOI. They asked us to do a full grant submission. We just submitted this grant for comparing two approaches to suicide prevention called safety plan intervention and family intervention for suicide prevention. In order to compare them and look at outcomes, it is actually a huge grant. All 12 nodes were involved in the submission. It's a $14 million grant, and keep your fingers crossed if we get it. We are already beginning to put these suicide prevention programs in place in all the nodes, but if we get the grant, we will be able to actually expand it tremendously and involve a large population. One good thing, again, Octavio, is this, as you know, is really engaged with patient-centered outcomes, and therefore we have a very vibrant patient and stakeholder advisory board for this that is statewide, and they gave us feedback, and not only feedback, they are collaborators with us. It will enroll to 1,741 Texas youth, 15 to 20, with a recent suicide attempt. This is the work that needs to be done no matter what. So before I go for questions, maybe ask Dr. Wakefield if you want to add anything to what I said. And she she gets calls from me all the time, so she can expand on this also.
I don't think there's much to expand on here. Thank you, Dr. Trivedi, for that great presentation. I just do want to reiterate how exciting it is to have these networks that will allow us to accurately assess the youth in our state who are greatly suffering so that we can effectively target our interventions in the future. And then secondarily, this is a great opportunity through our measurement-based care initiatives to improve collaborative care. We know it works in real time. And so just a really fantastic thing to be involved in, and I appreciate the opportunity.
One more thing, Joe, I see you there, Dr. Blader. I think this service utilization approach questionnaire was something that your real contribution. Do you have any thoughts? Just very quickly reading those through, but we can then have a separate call. You're muted.
Sorry about that. No, I'm just very pleased to see that it's gathering useful data for describing the sample, and hopefully going forward and looking at change in service use. And it's granular enough, I think, that if you get a robust enough sample on the combination of medication and other therapies, it might teach us something. I have a question though, Madhukar.
Go ahead.
This comorbidity with agoraphobia and social phobia in slide 26 is incredible. At 82% prevalence in the sample of agoraphobia, and then about 46% for social phobia. So that brings two questions, well, many questions, but a couple to mind. One is, do we know if the mini, as a measure of lifetime disorder, are we going to get any insight in this cohort whether the anxiety disorder precedes the MDD, as is often the case, or is perhaps people reporting a lot of withdrawal and apprehensiveness and so on, lack of secondary to mood disorder? That's my first question.
I think that is the question. We have not yet started looking through individually, Joe, on the data, but we should, and maybe we'll set up a time with you and do that. The second part, I think, is, you know this, but we got to be a little more, this is early. So once we get a 500 and 1,000, we'll know a little better. So one of the things that happens, as you know this very well, that happens in all our research studies is, in the beginning, we put in very severe people as they are coming in, because that's up topmost on most node PIs and everybody's mind. So we'll keep track of that, but maybe I'll send you a quick note and we can look at the data.
And then the other question that comes to mind that maybe we could talk about later is, given that those two anxiety disorders in particular, the likelihood of SSRI monotherapy, for instance, really being fantastic treatments for agoraphobia and social phobia is not great. So I'm hoping that the data we get on the type of other treatments that people were getting, preferably CBT with exposure, would be the gold standard if we'll be able to get an estimate of roughly how many are getting guideline concordant care versus not. And the fact is, in many countries, medication is, I wouldn't say deprecated, but is a lot further down the list in the algorithm for those two problems.
I think we will keep track of that. As you know, what we have done is purposely not be prescriptive about what treatment the doctors should use or the counselors. What we say is, when you use any treatment, and we provide information on pluses and minuses for all, but when you use any, focusing on measurement-based care and collaborative care is where we have spent. So we are not dictating or directing any of people to decide which. So you are absolutely right. We'll figure out what clinicians in Texas are doing in terms of the hierarchy, medication, psychotherapy, exercise. And in fact, we don't want to direct them to use one or the other medication, in fact. So. Right. Yeah, exactly.
But, just one more thing, and then I'll be quiet. That the idea of trying to look at such a granular level of what is actually going on when people come for these therapies turns out to be prescient in this context, because it really makes an immense difference in outcomes. So, good work.
Yeah.
So Madhukar, I'd like to ask you a question. It was a nice presentation and it gave us a thorough picture of what you're doing. Your current recruitment total is 200, and just keeping an eye on the end number, I think we promised the state with this project to have 2,500 at the end of this year, which is about 6 months. Are you confident that you can cross this, add these people in by the end of the year, which would be the end of August, I guess?
So
giving all the new sites that you're pulling online and everything.
So we promised 1,800 in this network, Carol. But yes, I think that like my belief is, and I'd love to hear from some of the node leads, like Jair and Joe was talking, and Dr. Wakefield, that the nodes are now primed, and I think you can see the rapid increase in recruitment. So I'm hoping that we will get to that number, but
good. We don't need to hear from those networks now. I just wanted to see, I just want to hear from you.
That's top of my mind. I've been some of my partners are not always excited to get my email, but yes, I'm working. We are working very and diligently on that. Although they've been good sports, so when I call Charlie, he kind of slaps my wrist, but then he's a very good sport on it. So thanks, Charlie. But yeah.
Well, and Dr. Taminga, I will weigh in here as both like a participating on the hub team and on the node teams, that I think that Dr. Trivedi's team, our hub team, is doing a fantastic job at, we know that our HRIs have such different research structures. Some of them have huge research infrastructures. Some of them have almost no research infrastructure. And the amount, this is just a secondary thing that's happening with these networks, but the amount of guidance at how to set this up and what to do from the hub team has been immense. And I've been very appreciative of that. And so I do think that, sometimes it's slower than maybe we projected. But a lot of that had to do with, we projected these numbers before COVID happened, and a lot of IRBs have had to flex in their, in their rules and the things that they have done to understand how to do research in the time of COVID, how to protect subjects, how to do these things. And we are doing a really great job of that across the network, but it has caused all of us to be a lot more thoughtful in the way that we have done things.
So Sarah, I know in addition to all the things you said, the research network started late. So that was another thing. But with the network structure that Dr. Trivedi described, it seemed like there was a great opportunity to take off and to actually reach the goal at the end. And that's what I was asking about.
Yeah, I think so. And I just want to point out how, one of the greatest things about these networks is that we are building this capacity in each of the nodes, and that the hub team has been so vital in that. And I've been on calls where they've said, okay, what is the structure of your clinic? How do you do this? Coming up with really, really granular type advice to improve the flow of research. And there's just, I don't know in what other setting you could possibly get that kind of consultation. It's really, really vital and important to setting this up for our future work.
Thanks.
Yeah, so Carol, we even get down to the level of creating flyers and working with each of for different. So I think the IRB issue at some point is a lesson learned, and maybe we work with Dr. Lakey and the system level, because some of the issues on these local IRBs could be enhanced by having a little more careful thought through. An example is some IRBs in the COVID arena are not allowing to get consent from participants unless they face-to-face see them. Now, they are willing to give them without face-to-face treatments, but they're taking away the right of these participants to participate because so there are some inconsistencies that the state system level, we can make some recommendations to local IRBs at some point. So there are things that can be done.
Why don't we have one final question? Dr. Keller, Andy, you want to make a comment or question?
Yeah, it was just a comment really. And I just think that, I think it's just cool that we're sort of having a research meeting here together, which, I suppose is good for the public to see kind of the thoughtfulness that goes in. I just don't want us to get lost in some of these details. And I think that the level of accomplishment here, particularly the thoughtfulness in describing what's going on, is a huge thing. And I know y'all are excited about like being able to do your predictive understanding sciencey stuff, but in terms of having this description of what our children and families are going through and documenting that as we go forward and being super careful about that, we're not pushing any particular kind of treatment here. We're just understanding what is happening and seeing tremendous suffering. And I think the numbers are very impressive given all the challenges that have been done. And I just want to say I was on part of a national consortium that's led by Josh Gordon, the NIMH director, and we've had a one-on-one talking about that. And I had a chance to just bring up where the networks are. And he reiterated just how exciting this is and how unusual it is to have a group like this. So I think that, I just think I don't want us to lose the forest for the trees here. Like, these are all interesting points, and I think it's part of the richness of making things forward, and shows how careful everyone is being on this. But it's very impressive, and I think that point needs to be the one we end on.
Yeah. So let me go to Dr. Nemiroff, and then I'm going to conclude, and then we'll go to the next topic. But Dr. Nemiroff, anything you want to add?
Thank you, David. First, to congratulate Madukar on what a wonderful job his network is doing. And just to give you a brief update on the trauma network, we have the exact same number of subjects recruited. So we've recruited 200. And we are also just submitted our letter of intent for a PCORI grant to compare 2 evidence-based psychotherapies in the treatment of children who've been traumatized. I think we can't overestimate, I know you don't want to get in the weeds, but I can't overestimate to you how much work it goes into having all of the nodes trained to a requisite level of inter-rater reliability so we know what the data is that we're getting. And what we're seeing is the same thing Madukar is seeing in his network, a tremendous severity of illness. The level of trauma, which I presented to you last meeting, is persisting. And so the need is unbelievably great. I don't know if Dr. Wagner wants to add anything, but certainly we're very excited, and we'll be starting to write up some of the findings. And for example, we can combine the depression trauma findings with the trauma findings into a large paper on the level of trauma that we see in our children, which is extraordinary.
So I concur with everything that Dr. Nemiroff said. And again, it's just taking a step back, the ability for these 2 networks to be up and running and recruiting and identifying these children, both with depression and trauma, that will have significant needs in the future, and particularly with regard to identification and treatment. The state has done an amazing thing by having us have the ability to have these networks and continue this project. So I think that the data speaks for itself. Things are moving smoothly and beautifully.
So thank you, Dr. Wagner, and thank you, Dr. Trivedi. I think, Andy, going back to you, kind of the bottom line that I'm hearing is that the networks are up and going, recruiting well. Obviously, a lot more work needs to take place, but meeting those expectations right now. And there's peer-to-peer learning and collaboration across all of our systems, which I think is amazing, that we are working across our systems and helping each other increase the level of research across the state. And with that, already looking at federal funding that will be brought in under PCORI to expand that. And so, going back 2 years in our conversations with the legislature, I think this is exactly the type of expectations that they wanted. And so congratulations to the group for doing so well and getting this up and going.
So if I could just say one more on that point, David, you took a risk on allowing or even promoting the research, but it sounds like from what you just said and the smile on your face, that research is done okay.
I think we're doing well. Again, a lot more work to do, but I think we are doing what we need to do, and it's being practical and improving the care of kids already in Texas. And so I think we're improving the quality of care, and also we're going to be bringing additional funds to continue to improve the quality of care. So I think, a lot more work to do, but congratulations to all of you for moving this forward. Thanks, Carol. So why don't we now transition? Actually, before I do that, we've had a couple of consortium members that have joined us. Dr. Leverzon, I want to recognize you, and Dr. Escamilla. I want to make sure that you are recognized. Anybody else that has joined us, if you'd recognize yourself at this time, that'd be great. Hearing none, why don't we move forward to the update on the external evaluation. And Dr. Savas, I saw you just a little bit ago. Why don't you update us related to the work that you're doing?
Great, thank you. So first, I wanted to begin by introducing a new team member we have with us, Jackie Klotz, who is working with us to build our databases. So some of you may have already heard from her. She's reaching out to identify and extract data from your existing systems and data sources. And we're compiling that so we have our master database of built on your systems, but we're also working to build our own database of primary data collection that we're planning to implement. And that, as we talked about last time, starts with establishing our baseline. And to do that, we have two different activities going on. We've completed we call it a process mapping. It's a combined of talking to people in the system who are the implementers to understand what is the implementation plan and map that out. And that establishes for us our baseline from which we'll evaluate implementation going forward. So implementation that is actually happening compared to implementation as planned. And we're planning that at multiple levels. So the HRI level, and then the clinic level and the school level. So even on the grounds, what each different school, how they've designed implementation of the program to identify and refer, for example, students to the program. And we're doing that. So we're doing it at the TCHAT and CPEM level. At the TCHAT level, we've been able to establish all the possible, so far this, the clinics, the schools that are have been identified, but we are still working on doing that within the CPEM level to identify all the possible clinics that have been enrolled in the program. And the reason why we want the universe of those who have been enrolled in the program is because we want to be able to select a representative sample to interview. So we want to make sure we're getting the rural, the urban, we're getting down to the level of trying to make sure we're including communities across all ethnic race groups so that we're able to really understand equity issues in the implementation and reach of the program. So that has been one of our challenges, is just figuring out what's the right now, the total population of clinics, because we're not going to be able to interview every clinic. We're sampling from those to reach out to. We need to know what the general, what the total population is. So that's one of our, right now, that's one of our tasks that we're still working on. The other level is we are going to be sending out a survey, and we've completed the survey. It's a readiness survey. So this goes out to organizations implementing the program. And so we're sending out to the schools, stakeholders at schools, and we'll plan to interview 2 to 3 different people at each site that we reach out to in order to have the different perspectives of how the organization works to implement the program, and same with the clinics. And this will give us an understanding of the different organizational factors that influence implementation. And so you may be hearing about that if your clinic partners or school partners ask you, what is this? We're sending out letters explaining our role, and we're going to be sending out that survey pretty soon. Probably, we're hoping that in the next meeting, we'll be able to report back to you some numbers of how the data collection is going in this on that component. Again, this survey establishes some factors that we'll be able to interpret results of, what are the priority groups that may need more support in implementation, what have done it, have been able to take the ball and run with it, different kinds of factors we look at and that we'll be sampling schools for to implement this include, again, I would say the demographic factors, but also in terms of organizational factors, things like at schools like centralization versus decentralization school models may influence how the program is implemented. So we're hoping to give you some insight into that based on these activities. And then once this baseline is we're complete with our baseline data collection, as we move forward, then we'll be able to measure the implementation as compared to this baseline. So I think that's the general, what we've been focused on this last month. In terms of scope of the survey, we're hoping to send it out to about 500 clinics and 250 schools. So we'll be working on getting that out and then following up to get as best response as possible. But again, that survey will cover the total area. So we're hoping to get a good representation from response from that. So like the main item that we need right now for moving forward is the list of enrolled clinics from the CPAM program. I don't know if my colleagues want to add anything. Jackie's been in the trenches building the database, extracting data from your system. So I don't, if we have questions, she's here too today, but I'll pause and see if there are any comments or questions.
Dr. Salvitz, Laura, I was just going to add, this is Melissa Peskin, the other evaluator that we're going to be sending out emails to in order to start the process of identifying people. We'll be on the lookout for emails from our project coordinator, Erica Frost, who's going to be sending out emails to all of the contacts at the HRIs to try to identify folks who can participate in those process mapping interviews, and then also to help us identify stakeholders at the clinic and school district and school level as well. So there's just a lot of, I think, connection and relationship building that we're doing right now to try to connect with everybody on the ground who's doing the work.
Very good. Any questions from the rest of the consortium, Dr. Salvitz or Dr. Peskin? Hearing none, it sounds like, Dr. Salvitz, people need to be looking for an email from you. And can you repeat that the person that will be sending that email to them?
You'll be getting it from our project coordinator, Erica Frost.
Erica Frost.
So she's been, yeah.
Okay. So everyone, keep a lookout for emails from Erica Frost. Very good. Thank you. All right, let's go to item F, the survey results and information regarding the child and adolescent psychiatric fellowships. Dr. Newland, you have a verbal report?
Yes, let me bring that up. 1 second. So we did a summary of our academic programs, and this is for kind of a report on what fellowship positions were funded by Senate Bill 11. Baylor College of Medicine, I'll start there, had 2 positions funded through SB 11 and this past year in 2021. And our program, UT Health Houston, funded 2 positions.
Are you wanting to share your screen, or you're just going to give the verbal report?
I
see. I hear you clicking. I wonder if you meant to.
I don't know if I can share my screen.
Okay, that's okay. I'm just helping out.
But
I'll mute. Go on.
I can go pretty quickly. UT Health San Antonio, you also filled 2 positions using SB11. Texas A&M and Baylor Scott White filled 1 position. UT Southwestern 1 position. UT Austin or Dell, you also filled 1 position using Senate Bill 11. And we have 3 programs that are working on establishing new child fellowship programs. Texas Tech and UT Rio Grande Valley have submissions that are pending, and so does UT Tyler for 2022. So that's very impressive. So that's the report.
So it sounds like what I have down here is 9, but I thought I saw something that had 10.
I wasn't sure if Permian Basin was funded through SB 11 or not, and I don't have a response to verify.
So we need to, you know,
They are not.
It's not by SB 11?
No.
Okay, so 9 through SB 11. And I guess to follow up for next meeting, if we could look at the total number of child and adolescent fellows that are training in Texas versus the previous year, to show that not only are these on SB 11, but the total number went up accordingly. I think it would be good. Anything else, Dr. Newland?
No, I think we'll just wait to see what happens with the accreditations that are pending. They're going to find out in April when ACGME meets next. So.
And it sounded like last time that there were some late matches after the formal match too, right? And so we need to calculate that into the overall picture of how we're doing for fellows in Texas, right?
Correct. So if anyone has a post-match fellow that they acquire, I guess just let me know.
Dr. Escamilla, see your hand. I can't hear you, Michael. It doesn't look like you're muted on Zoom. Maybe on your computer, your computer itself. Okay, you're going to type it in the chat.
While they're waiting, I wondered if I could ask a question about how did the child psychiatry match go nationally? Were there changes in the numbers from year to year? And were there many programs that hadn't filled? I was just curious.
Karen will be the one to know that most directly, I think.
As I recall, about 25% didn't fill, 25 to 30%. So it's still such a stark contrast to what we're facing with people going into general psychiatry, where there are so many qualified applicants for general psychiatry residency positions, especially in Texas, with probably not enough slots. I'll give an example of our site. For general psychiatry, we have 30 of our medical students that are going into psychiatry, and our program only has 8 spots. So, and the other programs I'm sure are similar or even larger in that problem. So that we can't recruit into child is problematic and being addressed by the field.
Very good. So I want to read Dr. Escamilla's comment. He notes that he just wanted to add that due to the House bill, 3 child fellowship programs are in process of starting. That's big. Elizabeth mentioned that, but I just wanted to emphasize it. And so again, to point out that not only do we have new fellows, 9 fellows that are funded, but starting off 3 new fellowship programs. And he also notes, we also have 3 residents going into child programs this year, all who are part of CPE. So good. Well, that's good, Michael. All right. Any other comments or questions for Dr. Newland? Hearing none. Dr. Martinez, let me get the update from you. You always do amazing work before each legislative session about the state of mental health, and would love to hear what you hear.
Thank you, David, and good morning to everyone. Next slide, Douglas. So one of the things that the Hogg Foundation does in the interim, especially the policy team, they work very diligently on what many of you already know as the Mental Health Guide. So it's a guide to understanding mental health systems and services in Texas. We originally created it a while back to really give everyone an understanding of the inter-system, not only budget, but I think coordination that needed to be happening for the state of Texas. I think that it's become a go-to manual for folks. 5th edition, as you can see. So we're very proud about that. And you can see that we designed it really mostly for our advocates and policymakers, but we also want families and individuals, anyone that is really interested in how to understand our mental health system and services in the state of Texas to utilize this, this tool. And they've done a good job of giving comprehensive summaries on all the different units. As you can see here, I'm not going to read them all to you, but they're listed for you from the obviously HHSC, which is the big one, but everything including juvenile justice as well as our Veterans Commission, all have great summaries in there. This is a link to, if you want to go online to take a look at the mental health guide, PDF form, you can download it. But also we do create hard copies, guys. I know we've sent one to David and I think one to Luann. However, I want to make sure that each and every one of you has a guide if you so wish. And my last slide, and you have the copy of all our slides, you'll have the email to send us a request. And please include, though, because of COVID-19, we used to deliver these in person, that will go to a mailing address, physical address, even your home address, and we can mail one to you. If it's grown considerably from its first initially 200 pages, and now it's 542 pages. It just goes to show the extent to how complex our systems are here in the state of Texas, but also we've learned over the course of the years that of getting more information. I'll also add that as you see anything, if you see any mistakes, you see any gaps or anything else you'd like to add it, please email us, because in the interim, we do take those comments seriously to try to make this a much better, useful and document that can be used by all. So it's a living document. We try to keep it updated. Next slide, Nagla. The other thing I wanted to share with everyone is back in late last year, the Hogg Foundation released the Mental Health Declaration of Racism as a mental health crisis. We all went through 2020. We saw how COVID-19 really unveiled the disparities and the health inequities in our system, and mental health is front and center as well. And also there was the social justice movement that really was taking on steam, especially in the summertime. And Hogg Foundation has been working on these issues for a very long time, but we did feel, because there were many declarations that had been released by other wonderful organizations nationally and even here in the state of Texas. But what we did notice was there hadn't been a declaration that was really calling out mental health. And we felt that was way too important and for us to have an understanding, and especially our own understanding from a research and clinical standpoint of how trauma really impacts us, be it man-made or natural. And COVID-19 is no different. And that's why I think the amazing work being done by our two research initiatives are just so important to what's going on, not to mention the standing up of the consortium, right? I mean, what great timing. It was talk about serendipity and kind of seeing the future and the needs, not only of Texas, but it was ready to take on something this impactful as COVID-19. And so we named it out. However, as you can also see, we've had, I'll let everybody know, over 183 organizations sign on, a lot of great Texas organizations and academic institutions, but also national organizations like the National Council has signed on, and we've even had some international organizations sign on as well, recognizing the importance of calling out racism as impacting our mental health crisis. And for those of us in psychiatry, especially, we also know that our American Psychiatric Association on January 18, 2021, apologized to Black, Indigenous, and people of color for structural racism as it has impacted their mental health. And there's ongoing initiatives at the APA level. Definitely, if any of your organizations want to sign on, it is an active document. The main reason for this document really is for us to let everyone know as a stakeholder that the Hogg Foundation takes the root causes of what really impacts and results in social determinants and inequity seriously. And racism is unfortunately a very significant one. Next slide. That led us to one of the things that we identified. We have it on our mental health guide. We put it in the declaration as well, which is the Hogg Foundation is asking for all stakeholders to consider, and especially also our policymakers, to stand up an Office of Health Equity at Human Health and Services Commission in Texas. We really feel that it will help correct inequities inherent in our at a systems level. And you can see here some of the key things that we've called out that the office could really work on. And the research initiatives, both of them really called out to the coordination that's happening, which is amazing at our HRIs. But the coordination needs to go beyond just health, as we well know. We really need to be including our educational system, our judicial system, and others. And I think one way where that can happen, and since it is so important that what we do is evidence-based, so that we can make informed decisions, it would make sense to, at least it makes sense to me, to have an Office of Health Equity that can coordinate that, and where it can really identify and eliminate systemic barriers as well to ensure that we're accessing healthcare services equitably for all of our citizens in the state of Texas. And then obviously includes especially our children and our youth and our young adults. As you can see here, could provide training and technical assistance, collect and analyze data, but also take a look at and come up with the health equity metrics that we can not only use as a baseline, but also to actually ensure ongoing improvement and quality of care. Programmatic assistance could be done as well, and then of course disseminating this to ensure that it's available to everyone in Texas, but especially our HRIs and all those components of the enterprise, HHSC. It also would really help to have someone looking at things at a state agency level, at new policies, rules, statutes, and so forth, through that health equity lens. I think what we know about disparities, what we know about inequities, and definitely the social justice movement, I think really should take us all, by storm of why we really need to do this. And what I really liked about what Madhukar was sharing, Dr. Trivedi, is the fact, and also mentioned by Dr. Nemiroff, how our kids are right now really suffering. And it's why, because we're gathering the data now that we can actually have evidence-based approaches that we can share, not only at the clinical level, but let's turn that into then informing our policy to make the right decisions and to ensure, as Andy often says, let's be the best at what we do here in Texas and be truly, I think, an exemplar for the rest of the nation. We've got the makings all here. I think the Office of Health Equity could add to that. We've done an op-ed. I wrote "Who is responsible for addressing racial disparities in health equity in Texas?" It got picked up by the UT News, the Statesman, San Antonio Express News, and we also were able to do a Texas Public Radio interview. Next slide. The other thing I wanted to share with you is because it has to do with kiddos, very much so, and from a programmatic side, since we are a foundation, is that the Chan Zuckerberg Initiative reached out to the Hogg Foundation late last year, wanted to work with us on addressing the mental health and well-being for youth of color and their families here in the state of Texas. So they gave us a small grant. I mean, these guys are billionaires, but I'm not going to look a gift horse in the mouth and someone's offering me 1.1 million. So we said yes. We're hoping this may be the beginning of a relationship with CZI. If you're not aware of, Priscilla Chan really kind of has set the environment of where the initiative wants to address issues. and children's health, and especially for kiddos of color, is really important to her. So it's important to the CZI. And so, as you can see here, my program team is currently working diligently on creating and identifying the grantees. It'll be, as you can see there, looking at already existing or expanding partnerships with Texas pre-K through 12 schools, especially those that are programs designed to improve academic achievement, enhance community conditions, and including mental health and overall well-being for these kiddos from a strength-based approach. Hopefully in a few months, we will be releasing who we've identified as receiving a letter of interest, and it'll be across the state of Texas as much as we're able to do that. But we're such a huge and large state that though it's a wonderful initiative, we could definitely awfully use more. But in case you hear about the CZI Hog Foundation initiative, I wanted you to be well aware of that. Next slide. And then just thank you all for the wonderful work we're doing. It's just super excited about what's being shared with us today. The Hog ED, please, if you're interested in getting a mental health guide, send us an email with a physical address. We can mail it to you. And also want to point out, it would taken way too long because it's a 19-page document. Our 87th policy priorities for fiscal year 22-23, which obviously includes, definitely we're in the midst of that. And you can go to our website and download that to see all the other pieces of mental health and substance use that the Hog Foundation is advocating for. Now, remember, Hog Foundation, we can't lobby, but we definitely, when reached out to, we can provide, guidance, do a brief, whatever the stakeholder or policymaker is asking for. The good thing about the Office of Health Equity, I'll just end on this. We have had some interest, and more than I don't know if it's 2 or 3, 2 for sure. One senator, no, so it's 3, and 2 representatives. Obviously, I can't say who those are, but who are interested in definitely taking seriously the potential of creating that Office of Health Equity. And I reach out to you as my colleagues that if this is of interest and you have the possibility of being able to advocate for in your sphere or realm, please, by all means, do. And with that, I'll turn it over back to you, David.
Thanks, Octavio. Any questions from the group for Dr. Martinez? Dr. Trivedi, I see a raised hand. I'd also encourage people to do the online or the raise hand function so I can see your hand. But Dr. Trivedi, you had your hands up? Dr. Trivedi, I can't hear you.
Dr. Martinez, wonderful. Thank you for your, I couldn't help but point out that the mental health resources needed in the Texas criminal justice system would go down if we spent a lot more effort in schools and with young people to identify problems early and make some interventions there. So we're chasing our tail by doing that, which we should do because that's the landscape we currently have, but more effort in the early stages would actually reduce that quite a bit.
I totally agree with you, Madhukar. And in fact, through the Judicial Commission on Mental Health, and Andy and other stakeholders here that are part of that as well on the JCMH is looking at the intercept model. And to your point, Madhukar, it is so important to really be more population health focused and move more upstream, and let us not get to the point that kids are being introduced into the judicial system, because we know the long-term impact. And to that point, I'll just add, I didn't include in one of the slides, but there are members here that were part of the group. The Hog Foundation did bring together key stakeholders to that respect. And also we're putting forth, and there's interest as well as this in standing up an office for forensics at HHSC to oversee the big picture and to see those interconnections, as you're pointing out, Madhukar, between different systems. So I know Meadows Mental Health Policy Institute with Smart Justice is involved in this. Obviously, the JCMH, as I mentioned, and others. So I want to thank also that point out that we are looking at that. I don't know if you want to add anything, Andy, because you guys are doing some really good work there as well from a forensic standpoint.
Well, thanks, Octavia. I appreciate that. I think the only thing I would add is that I think law enforcement is the key point, and I think really exciting stuff happening in Austin this week with the partnership they have with Integral Care and the paramedics and the police there with the CARES program. So I think starting this week, you're going to be able in Austin to, when you call 911, there'll be a fourth option where you can just say mental health, and you will go directly into a mental health queue and circumvent the police. And this builds on reforms that we have in Dallas, we meaning the state, and that we have in Abilene, we have in San Antonio, that really provide a non-police response, a paramedic and mental health response when you call 911. And that really augments the mobile crisis response that we've had, statewide. I mean, we have an amazing mobile crisis response that I think a lot of times we take for granted and that other states do not have through our local mental health authorities and the partnerships they have. But to be able to now take it to the next level and have people call 911 and not have a police officer come is a pretty amazing thing, which it's also amazing that we have to call it an amazing thing because that's what automatically happens for every other healthcare condition. But I guess we need to celebrate them as we go. So thanks for pointing that out, Octavia. I think it is really important.
Yeah, it's a
Very
great
good.
development, Andy. I totally agree.
Let's go to Ms. Wesley and then Luann, and then we'll need to move forward on the agenda.
Yeah, thanks, Dr. Martinez. Great information, and I'll probably be connecting with you offline. I guess the question would be is that if we have school partners and or other community affiliates that perhaps might be interested in the resources around the promotion and education of children of color in terms of accessing mental health services and things of that nature, do we reach out to you, or how do we get in contact with some of our stakeholders, perhaps linking into those resources for the CZI funding?
Yeah, go ahead and just contact me, Danielle. That'd be probably the best efficient way to do that.
Luann?
I just wanted to mention how important the resource guide is for all of us working with children and families, because as you know, when children present to us, they are often engaged with other systems like child maltreatment systems, juvenile justice systems, special education, et cetera. So it's important for us as a consortium to see how our services that we provide fit into that greater continuum of services for children's mental health across the state. And I know Sonia is going to talk specifically about HHSC, but in the past, when we've looked at financing and how children's mental health services are purchased and who provides them, it is extremely important for us to look at that and not duplicate efforts, but see how what we are providing enhances that broader system. So I always appreciate, Octavio, your resource guide, because I think it really helps us see where we fit.
Thank you, Luann.
Very good. Yeah, I would encourage everyone, if you don't have one of those resource guides, what I call the Hog Bible on mental health services in the state of Texas, to order one, because it will be very helpful to you as you figure out how this complex system that we have put in place in Texas tries to work together. So thank you again, Octavio. Why don't we move now forward and Sonia Gaines have the update from HHSC.
Good morning, all. So glad to have the opportunity to present to you all this morning. And one of the things I thought would be helpful, in addition to talking about HHSC, on the very first slide that we had, I thought it would be a good idea to talk about the work across the state agencies. Many of you know that the statewide behavioral health strategic plan, which was published back in 2016, had and really required by legislation, pulled together 23 state agencies. Some of you are sitting around on this call today, as well as many others, and with an effort to have a unified approach to behavioral health services. And I can say, you can look at this chart and see that there's been quite a bit of progress across all those 23 state agencies, over the past 5 years or so. We still have some ways to go, though. I think many of you recall some of the major goal areas that we've been working on, some of which include coordination, service delivery, early intervention and prevention, financial alignment, and also data collaboration. We took the liberty of highlighting some of those things on this progress chart that really focus on services for kids. And you can see in 2016 was our first statewide behavioral health strategic plan. And then if you move forward in 2017, we had the mental health grants that Andy had mentioned earlier. In 2018, we had a summit that included many of the child-serving state agencies. And they continue to do that on an annual basis. That's something also, Dr. Lakey, I think we need to have representation from that group to participate in that summit as well, because I think that's important. 2019, the development of our residential treatment beds, and I'm going to talk a little bit more about that in a minute. And then 2020, you see probably our greatest success areas. That's when the Texas Children's Mental Health Consortia got developed. And you can see many other initiatives, including mental health first aid. So we're really, really pleased at the progress that's been made from this unified approach across all these 23 state agencies. And I think we're well on our way to seeing bigger and greater things as we move forward. Next slide. So I want to jump into the services that are offered through, mainly through contracting, that Health and Human Services has contracts with our local mental health authority as well as other nonprofit organizations. But I think most of you are aware that through our local mental health authorities, we have been able to provide community-based mental health services to eligible children and youth. And some of those services are listed here, including counseling, skills training, medication management, family partner services, as well as crisis intervention services. One of the things that I have really put a lot of emphasis on being at the state and working with my team is for us to get good at understanding what the impact of the services are that are being provided. And one of the things that we've come to realize is that 98% of the individuals receiving local mental health authority services remain in the community and do not require inpatient care. We also know it's a good value. Those services average about $13 a day. So that's a pretty great value for community-based services versus inpatient services. Next slide. On average, we serve close to 25 to 20, anywhere between 25 and close to 30,000 children across the state. And so this chart depicts from 2014, you can up to 2020, you can see the tremendous growth. We've almost doubled the number of individuals that are served. But more importantly, if you take a look at that red line, which depicts the individuals waiting, we have not had any children waiting in 2020, and the numbers have been very low since 2018. And I would say a lot of that is in part to the tremendous support that we have received from our legislators, over the last several years. I think there's a definite interest in understanding of the value of having these services readily available. We also know when the services are readily available, people are likely to show up for those services when they don't have to wait. So, and particularly during this pandemic, this has been a godsend to be able to have these services immediately available to people that are eligible. Next slide. So many of you have heard about our youth empowerment services. Those are services that we contract through we work with our local mental health authority as well as some of the private providers. These are services that are developed to work with children that need more support than what they're going to get from traditional outpatient settings. Also, in addition to working with the child, we also have teams that are working actively with family members and helping them to learn new skills, that have been very instrumental in keeping those children in the community. You can see enrollment has been between 2,600 and 2,800 for the last 4 fiscal years. That's a tremendous benefit as well. I remember when I first came to the state, less than 100 kids were being served. So now we're close to serving 3,000 kids. But one of the most important things about this program is that we know it has a high success rate. So we're seeing increases in family and community support. We're seeing significant decreases in crisis services and decreases in inpatient stays, as well as significant decreases in child relinquishment services. So this is a program that has also worked very well for kids that are coming out of the judicial system. And we're able to fast track those individuals into these services. Next slide. The next one is about residential treatment centers. I mentioned that a little bit earlier. One of the things that we realized is that I remember when I first came to the state in 2014, there was a recognition that there were a large number of kids that were being relinquished and ended up going into the foster care system. And so I remember us sitting around the table with a lot of the folks from DFPS and a number of other stakeholders trying to problem solve what is a way, for us to deal with this. And so one of the services that we put on the ground is these residential treatment beds. This program has been hugely successful. We have about 50 beds that we contract through RTCs across the state. On average, we're serving about 100 kids per year because the average length of stay is about 100 is about 6 months. We're finding that there are about 32% of the individuals that go through this program successfully are diverted from community mental health services. And many of them are staying in the community in terms of a very, very high percentage of the folks served are staying in the community. Next slide. Next one, many of you are very aware of our coordinated specialty care services. We are close to serving about 1,000 individuals. That's a major milestone. This is another area I remember. It was a challenge getting off the ground, but now this service is widely available. We recently expanded to 24 sites, and not only do we have this service available in our urban areas, but we were able to expand to some of our rural areas. I do want to thank some of you sitting around on this call today. Like Meadows was very instrumental in bringing this to our attention about how valuable this service has been, as well as the Hogg Foundation. And of course, the Texas Council has been instrumental in helping us to put these services on the ground. You can see here with this program, about 67% decrease in hospitalizations, 28% decrease in jail admissions, and close to 70% decrease in crisis services. This has been a pretty phenomenal program for individuals ages 15 to 35, dealing with a first episode of psychosis. Very, very excited about that initiative. Next one is one that I think should by now be near and dear to all of your hearts. Mental health first aid training. This is one back in 2014. There was some legislation that prior to that was sponsored by Senator Schwartner to get the educators trained in this 8-hour training, mental health first aid. It's a national training, best practice. You can see from the progress chart there, we've made huge success there. We've gone from serving less than 3,000 people in 2014, and now that number is up to over 100,000 individuals that have actually been trained. And in big thanks to the local mental health authorities and local behavioral health authorities for the tremendous effort that they have put in to get these services on the ground. And what we know is the more educated people are about, mental illness, the more likely they're going to be able to respond appropriately. So I've been very, very pleased at the progress that we've made through these services. Next slide. Okay, the next one, you heard Andy talk a little bit about our community mental health grant. We have a number of initiatives. Over 10,000 children have been served through our community mental health grant program with various directed projects. You can see there, and this is just focusing on children. Over a little over $3 million of the funds are focused on services that are focused on children. And those services we can find them in about 10 of our counties, 9 different projects, and more than 8 directed different service types. We know that 88% of the youth in school-based programs with measurable improvement in pro-social academic domains. So we're seeing a lot of great progress there as well through our grant program. Now, one of the things that I did not put on a slide, but it's worth mentioning, is that we also have the Veterans and Children's, the Veteran and Family Grant, which Sarah Nelson had sponsored. That one has also been hugely successful. A number of children and family that have also been served there as well. Next slide. Substance use disorder treatment expansion. Many of you know that we had received a little over $5 million in funding that was used to amend contracts. 80% of our substance use disorder treatment providers to expand state-funded treatment capacity for pregnant women and their dependent children. So with this expansion, this will result in about an 11% overall reduction in our wait list. And that was funding that we had gotten last session. Hopefully, now this is one of the things that we saw with this particular funding. This funding was not included on the Senate side. When the bills came out, it is on the House side. We're hoping that it could be fully funded as we move forward. We're trying to work with folks on that to help folks understand that. Next slide. mentalhealthtx.org. Some of you may recall we had started this website. When I first came to the state, I realized that we did not have any web-based or very little web-based information about mental health resources and how to access those services. And so we put together this mentalhealthtx.org webpage, and I call it a web page back then because it was, pretty simplistic, but it did the job. Most recently, we were able to do some major to this website. And thanks to our, we partnered up with university partnered to pull this together. And I'm really excited about the improvements. The first and foremost thing is that we are now have this website available in 64 languages. So someone going to the website, if they or have a different language other than the English language, they can click on a list that will allow them to pick those languages. I'm hearing from my staff that we're getting national attention for that, and we're seeing a huge increase in people coming to the site, just getting general mental health information, because apparently that sort of resource is not readily available across the nation. So that's one thing that we're very excited about. The other thing is that there's tremendous educational materials there, as well as a service locator. Again, I think it's important that people have access to care when and where they need it. And so they can literally go in and put in their zip code and find where their local substance use or mental health provider is. Next slide. Many of you are aware of the work that we did in response to COVID-19. And so one of the things that I'm really pleased about, and in part, we were able to, stand up this COVID mental health support line, in part because of the infrastructure that we already have across Texas. We are required, every one of our local mental health authorities are required to have a call center that is manned 24 hours a day, 7 days a week. So in general, all of them have been able to respond. But if people didn't know what number to call for their local authority, we marketed this number for the COVID support line that was manned by our Harris Center in the Houston area. So far, we've gotten over 11,700 calls, and that's since we stood the line up in March 31st. And it's covering close to 200 of our counties. They've also hosted virtual support groups for frontline health workers. That has been a huge success as well. And then in addition to this COVID support line, again, on average, our local mental health authorities are still taking anywhere from 10 to 14,000 calls on a monthly basis. So we have a huge support network, I would say, here in Texas through those call centers. Next slide. The next resource that we were able to bring up was the crisis counseling services. We received a couple of grants totaling over $25 million that allowed us, again, to work through our local mental health authorities. So to provide this crisis counseling service across all 254 counties. Those services are strength-based, anonymous, outreach-oriented, and conducted in a non-traditional setting. Next slide. This just gives you some stats of the work that's gone on in terms of crisis counseling. And you can see it's been pretty tremendous when you add up just the numbers on individual counseling. Close to 20,000 individuals have been served. More than 30,000 groups have been served through this crisis counseling resource, and millions of people touched by social media and emails and other types of education material. Next slide. Looking towards the future, what are we working on? We're working on a number of things. Didn't have time to talk about everything. But I know Andy's already talked a little bit about the 1115 waiver that's extended through 2030. We're excited about that. I do want to say that this is, however, not new money, but it allows us to continue some of the work that was funded through, some of the other, through the other 1115 that we had. So we're very grateful to have that resource. But one of the things that I really want to talk about is our certified community health clinics. We have a goal of certifying, all of our local authorities by the end of 2021. Today, we have about half of them that are certified. And so you may ask, why is that so important? It's important because it creates a system of care. It creates, I'm talking about this in terms of it being new and improved. And it's also foundational to the new the recent waiver that was extended. That was one of the things that we put in the waiver application, that we were going to use that model. And for those of you that aren't familiar with that model, some of the exciting things about it, the model is that it does require, care coordination. It has a strong integrated health component. So we're looking at, substance use as well as primary care services. It also has a strong peer component to require that peer services be a part of that service delivery system, as well as crisis services. And it's just been a tremendous benefit. I hear such great feedback from our local mental health authorities that are already involved, but it also gets us to some consistency across all of those authorities and even greater efficiency and effectiveness. So I'm really excited about the movement towards, getting all of our centers certified on that. We've also gotten word that Texas is slated to receive additional funding regarding our mental health and substance use block grant. So we're very, very excited about that, given that this is going to be a tough legislative year. We did not have any exceptional items, but certainly we know where the gaps are, and we will be able to use these dollars to address some of those gaps. And then the last thing on this slide is 988 Mental Health Crisis Hotline. That will go live in 2022. We're gearing up for that. We're very, very excited about that, and it will create a number very similar to 911 or 211, but it will help people, give people a number that they can remember and they can call directly when they need help or information about how to access mental health services in Texas. Next slide. And the last thing I want to mention here, and if I can figure it out technology wise, I will put in the chat box a copy of our annual report that we did for 2020. Many of the things that I mentioned here today, you can find there, or you can go to mentalhealthtx.org and you can actually get a copy of our 2019 version of our strategic plan, as well as the latest updates on the strategic plan. And that concludes my presentation. Any questions?
Very good. Thanks, Sonia. Any questions from the consortium?
So I don't have any questions so much as I am just compelled to speak about the series of presentations that we've just heard, including the work being done through the TCMHCC. But certainly, Sonia, you kind of encapsulated many of the things that are underway today and those that we are reaching for in the future. And it is actually quite amazing to me where we are coming, where we are going, where we are. And I thought I just wanted to grab one thing. And Sonia, you had a slide that talked about mental health first aid and the training for educators and others that have been added on through a couple of legislative cycles as we have begun to really reach out and provide that training throughout the state to a variety of audiences. And that might not seem to be the most important element of what you talked about, and yet it is so foundational to where we are today. Because I think back to 2013 and prior to that, where we were in a circumstance in which we really didn't talk about and really couldn't talk much about the mental health needs of children. And we certainly couldn't talk about mental health as it might relate to our reaching out to schools and engagement in schools. There were so many fears that we might in fact cause a problem, when in fact so many of us knew that we were not addressing well a problem that we needed to address. And I've heard comments today about how important it is for us to address the mental health needs of children, and how over time we could see less demand from adults needing care. And we know this to be true. We've seen it happen. We've been able to intervene. I think about the coordinated specialty care you talked about, Sonia, and what we've been able to see happen there for children when we are able to engage as we should early on in a child's life. But mental health first aid, you were talking about Senator Schwertner and the leadership role that he played in terms of putting a bill forward that would provide some level of funding for us to provide that training for educators, for children, for teachers and people who are touching children through our schools. And in fact, this wasn't quite as dramatic as the Senate Bill 10 provision bill going into Senate Bill 11 on the floor the night that we were all watching that happen and afraid that Senate Bill 10 was going to not make it. It wasn't quite that dramatic, but in fact, getting that bill through required Representative Coleman on the House, very liberal, left-leaning legislator who's been working on the mental health front for many years, working with Senator Schwertner to ensure that they would be able to get that bill through, the provisions of that bill through that legislative session. What was important about that was a policy statement being made and a transition coming to play in which we would begin to change not just the trajectory of children, but the trajectory of our system, and allowing us to focus and have the kind of conversation we're having today. And so I just think about how far we've come. I think about how hopeful we are this legislative session when we thought there may not be any funding available, where in fact the base bills have come out with funding to support the work of the TCMHCC and the ongoing efforts that are underway today. And just how grateful we are to have the voices around this table. Well, this isn't really a table, right? It's a Zoom. But around this Zoom, having these voices, adding to, contributing, and carrying the importance important role that mental health service delivery and just our ability as a state to respond. So we're no longer just talking about the fact that we've been for so many years the lowest funded state in the nation when it came to mental health service delivery, but we're talking about some really incredible and good things. And we're talking about ways in which the legislature has invested in this system. And we're working on how to coordinate that better on behalf of our citizens. I just felt like it was important to make that statement.
All right, very good. Dr. Martinez, let me go to you, and then I know Dr. Keller has a question, and then we'll need to move.
right,
Actually, there may be one other. It looks like Stacy Silverman has her hand raised under attendees versus panelists. So let me check with my folks to make sure that we have her registered right. But go ahead, Octavia.
Okay, thanks, David. I concur with everything Danitza said. Absolutely. And it's just a comment really to Sonia. The amazing work that's being done at HHSC that really exemplifies the investments that have been made by our legislature over the last 4 legislative cycles, building upon it, so guys. But just want to say the mentalhealthtexas.org with 64 languages, kudos to really to HHSC and you, Sonia, because that really exemplifies the commitment to health equity, because you got to be responsive to your community that makes up the diversity of Texas. So thank you.
Dr. Martinez, I would be remiss if I did not give credit where it's due. And I have to say that was Jeanette, the Texas Council, really insisted on that. And we worked hard to get it done. It wasn't easy, but I would definitely agree with you. It has been a huge value and really a focus on equity across the state. I mean, I had no idea of the benefit, and we're definitely seeing the benefit now, but thank you for that comment.
Let me see if Dr. Silverman can say anything that we can hear. She's listed as an attendee. So I can't hear her. So I'll ask my folks to see if we can get her admitted to the overall as a panelist. But Andy, let me go to you. I know you had a question or a comment.
Yeah, well, more a comment. Sonia, first of all, thank you for that overview. Or I guess Commissioner. I mean, because we're calling me Doctor,
Sonia,
I don't know. Anyway,
Sonia.
Andy, Sonia. Well, you have to call me Andy then, otherwise. So anyway, so in our official capacities, that was super awesome. And I really just want folks to think through, like, look at the system we have. And Danette, I really appreciate your kind of the piece you're talking about, because I do think that was a huge pivot point for us to begin to think, hey, we're all doing cool things, but how do we bring that together? And so if you think about the consortium's infrastructure, bringing together primary care, our local mental health authorities, our major hospital and health systems, now being able to have, coordination networks, research networks across them all, quality improvement, the really cool overview we had earlier today about the independent evaluation, looking at how all these pieces are coming together, how we can address equity, how we can fit all that in. I mean, it's amazing, y'all. And I just wanted to share, and some of you probably heard this already because I'm sure other people are multitasking and covering other meetings as well with their teams. But this morning in Senate Finance, when Senator Nelson and Chair Nelson laid out to the committee the things for the year, she spent a lot of time talking about mental health. And I got her exact quote was, "Thank God for the consortium." She talked about how, fortuitous it was that, when we came together and thought about how do we respond to the needs that we put the consortium together for, which were around violence, trauma, suicide rates, we put something together robust enough to care for all of our children. And now with COVID, she was just able to talk about how that is. And I just want us to say too, that last bullet on Sonia's page is one we all need to think about, which is the enhanced mental health and substance use disorder block grant funding. If Texas gets its proportion, as we should, from the additional $4.5 billion that's added in the current bill that's before the Congress, in addition to the $4.5 billion that was added just before Christmas, we're looking at hundreds of millions, if not close to $1 billion additional dollars to spend over the next year. And that will be hard to do. But just to tell you where we could go with that, I mean, look at what Sonia presented on our coordinated specialty care. We have almost 1,000 Texans receiving that. We have about 6,000 Texans a year who need it. So being able to scale that up and to bring it up and to have to do that in partnership with the people around this table, to use Danette's metaphor, because we need additional resources. That requires psychiatry. It requires qualified mental health professionals. So we all need to, in addition to focus on kind of keeping going forward, think about how we will take advantage of that. And I think it's not just we can think of those as one-time funds, but I really believe that the intent of the Biden administration, if you look at, some of the people they put in, the person they put in at the Department of Labor, who's going to be overseeing parity enforcement, and the comments he had last week about the importance of treating mental health as the equal arm of health that it is, as well as substance use disorder treatment. We should make a big run this year for trying to build up the services that Texans need, and then really look for this enhanced federal funding. And I think the community behavioral, the CCBHCs, are really going to be a huge part of that infrastructure, but we need to do that in partnership with the consortium members, because that will be hard to ramp that up. So we should feel thrilled about what we've done, but we have a year that if we do not ramp up, we will miss out on a significant opportunity to improve mental health and substance use disorder services for Texans.
Very good. Thank you, Andy. Sonia, anything else from you?
No, that'll do it. Thank you.
Any other questions? And Dr. Silverman, I think you're now fully into on the panelist side. Anything that you wanted to say?
I just wanted to congratulate you all. You've done such great work in such a short amount of time, and just kudos and well done. Anything the coordinating board can do to help, we're definitely here to help. So
great. We really appreciate you guys' support. It's been awesome. So thanks. All right. Number I, any additional updates? Is there any other updates we need to make? Loanne, do you have anything else? Okay. If not, I'm going to move forward to the update on the COSH, and just kind of planning wise, I'd like to get us done by about 1 o'clock. I know some people have some other activities or other meetings that they're getting pulled into, but we have about 45 minutes left then. But if we need to go a little bit over a week, we can, but that's kind of my goal. But let's go ahead, and Dr. Williams, let's start with your update related to the COSH activities.
Hello, everybody. I think that's possible for us to get through. We have a few just agenda items where we'll pause because we need input from the executive committee, but other than that, we'll just sort of be running through sort of some of the numbers. So go ahead to the next slide. Maybe. Edith? Okay. So again, we're going to talk about sort of operational updates, and then each of the 3 initiatives, and then the centralized referral system that we've been working on. And that actually is a collaboration that we're doing with the state. So this is not, again, this idea, we're not trying to build things just by ourselves. We're trying to work all together. Next slide. So as Dan had said at the top of the meeting, we did sort of finalize our contract with TPS. And so we've started to put out those monthly email to the TPS group. We do send sort of pretty much a pretty similar email to the Texas Family Physicians group as well. And so again, we're really trying to get in front of as many of the eyeballs of the primary care physicians in Texas through the sort of the regular sort of state level processes for information related to CPAN in particular. We did have a conversation as directed by the consortium executive committee to the CPAN state group. And the conversation around social media, there was a decision to not move forward with a Twitter account that was based on pretty much the conversations that were had in this meeting, that they just didn't feel like that was necessarily the right forum for the information that we might be wanting to provide related to CPAN. However, there was still a sense that Instagram could potentially get to the providers that maybe are generationally more inclined to use Instagram instead of Facebook, for example. Because remember, we already have Facebook and LinkedIn as the 2 platforms that we're using. And we were also asked to look a little bit more closely around how to have that site be as appropriate as possible. So in addition to the Baylor guidelines, there was recommendations that would be that the Instagram account would not have the ability for people to make comments. So there would be no comments to be moderating. It would only provide information that was specific to CPAN and nothing else. So again, articles, information around events, things related to CPAN would be the only content that would be provided on the Instagram account, in addition to the additional guidelines that we'd already sort of agreed to. So again, our goal would be for the COSH to manage those 3 accounts as we currently manage the first 2, the CPAN and for the Facebook. and the LinkedIn is that we would add Instagram, and the information that would be provided would be the same across platforms. So it's not, from our perspective, not a lot of work for Kosh to do, but we wanted to have an opportunity for the executive committee to see this information, anything else they wanted us to consider, and then whether or not we can move forward. So I'll pause for conversation.
Any comments from any of the other executive committee members? It seems like this is a very controlled way that we can make sure that you have control of what information is out there. And again, with not having comments, so you don't have to police them or have people saying things that are inappropriate or bullying other folks, et cetera, that could occur on a site like that.
Laura,
yes.
Joe?
can we have a link so that people who want to comment can get with you directly in case it turns out to be, and then get their permission if it's a testimonial or something, something that we might want to publicize a comment, and then we can incorporate it. So if I've had an experience with y'all, I could, there might be, contact us with your comments or questions. It's very easy for me to say, wow, you guys were so helpful. And then we could post that because it's advantageous.
I don't know if, again, I'd actually ask Edith, who's more involved and engaged with using social media.
We can maybe add like an email where people can send in comments if they want to.
I think our biggest thing was just to not have it be part of the thread where people could be.
Right.
Yeah, absolutely. But to the extent that you might come across the occasional thing that is beneficial for us, so we make it easy for people to communicate with us by email, as Edith mentioned.
Okay.
Absolutely.
All right.
All right. So it sounds like we're going to move forward, and we'll take Dr. Blader's suggestion about coming up with an email that we could put there for people.
Anyone opposed for us moving forward? Again, just want to be real formal on this. Okay. Hearing none, I'm going to take a quick little voice vote. We have a proposal to move forward with a social media plan with the guidelines that Dr. Williams has laid out. And do we have a motion to move forward with that?
So presented, yes.
So presented, Carol. Do you have a second? Second from Dr. Wakefield. Any further discussion? Hearing none, all in favor of moving forward, signify by saying aye.
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 Opposed, nay. Any abstain? So we have a unanimous voice vote. Thank you.
Thank you very much. Appreciate it. The next is just a few things. We have continued to do some presentations. Luann had asked us to work with her to present to the Superior Health Plans and the Texas Association of Child and Family Services. That was a very great conversation that we had with their team. What it also brings to mind is that we are working to talk about how we organize across the hubs, providing presentations and information. There's never been this idea that Kosh was going to do all of it, but we do think that we could potentially be the team that can kind of help organize it again. So to that end, Dan and our team has also been working to have a sort of a across the state meeting with some key individuals around that concept of outreach and education. And so we are going to be working sort of how to have a more laid out plan. And so maybe at our next meeting, we may be able to sort of share that with the executive committee. But there's a lot of great things happening at the local level that Kosh does not want to stop. We want people to keep doing that, but we also want to make sure that we can maximize any kind of a sort of state or national presence and really make sure that all the teams have opportunities to be engaged and do presentations and sort of talk about the programming that we're doing. Next slide. So the Data Governance Council met, that is chaired by Drs. Pliska and Vo. The primary discussion for the last meeting was around the data definitions, specifically for TCHAT episodes of care. And I will update everybody about that nitty gritty when we get to TChat slides. And as I said, we're just continuing to outline the data definitions to build that library that we've been discussing the last few times. Anything, Dr. Pliska, to add?
No, we can wait till the TChat update.
Okay. So now we'll go ahead and move forward to CPAN. And the next slide, we do have 11 of the 12 teams fully operational with Lantana platform, providing consultations across Texas as we've been doing since May. And we have been working with the external evaluation team to help them get training and be able to access the information related to trait so that they can do their work that they need to do with their external evaluation. We'd already been doing that with the internal evaluation team. This is now just a second step to be moving forward with working with the external evaluation team as well. So implementation topics, there has been a couple of things that we've been working through in the last few weeks and months, as we're all aware. So I just want to give everybody kind of a heads up where we are landed with some of these and also ask for some feedback from the executive committee. So we have had a lot of conversations about clinic enrollment, and certainly it's been a pain point from the PCP's perspective, as well as from the HRI's perspective. I want to remind everybody that we decided of spring of 2020, gosh, it feels like it's been eons ago, but we had several conversations at the executive level around sort of having a CPAN agreement. And the decision had been made that we did want to have an agreement that clinics would need to sign their name that they are agreeing to be a part of the CPAN process. So that has just been a little bit of a pain point. And so we, particularly with COVID, has been even worse because we can't go directly out to clinics like we had, most of us had planned to have the agreement there, to have them to sign. And so we've tried a couple of different versions of how to get this programs to clinics to enroll by signing that form in a couple of different ways. And there still is problems with that process. And that people are still concerned that it's potentially making people not want to participate because of the agreement. I did speak with David Lean and Dr. Lakey and Luann early in December about sort of, is there some different ways that we can manage this issue? And we had gotten some guidance that we could move forward with starting with a verbal as the yes, we've agreed, because COVID has made it hard to have a written document potentially sent back to us. So we went back to the trait team and said, you know, we are allowed to sort of move forward with sort of getting it in this sort of format. So trait has been working to develop a process in their onboarding system where each HRI could click and say that they have gotten this agreement, and then that would satisfy that the clinic would be enrolled. They have a workaround right now because that's something that they're working to build. So for right now, for teams, as I've told all the HR hubs, if you have a team that for whatever reason can't get you the written form, you can then sort of just tell the trait team, yes, this clinic is active. And then the trait team will go on the back end and fix until they have that final fix with the process that would be the HR team can sort of lead that. But again, I know that it's been a challenge for folks. And I know that people sort of wanted to have a conversation about, do we need to have it be a signed agreement? Can it always be potentially a verbal agreement? Just as a sort of reminder and a framing of this conversation, we did ask a bunch of states how they did this. And it was accurate that some states did not ask us for PCPs to do anything, is to just call. Others did have some sort of form that a clinic had to complete to be sort of considered to be enrolled. And others had even more sort of stringent, like in order to participate in the phone line, you had to do X, Y, and Z. So I think Texas kind of fell in the middle, where we said we want to have you sign an agreement that's basically your enrollment process, but not that we are necessarily asking of you PCPs to do anything. So I'm going to stop right now and see what people's thoughts are around this sort of issue.
I just wanted to say that we have a lot of PCPs that are calling and asking us questions and coming to our events, but not a lot of them are going back and doing that second step of getting whoever's in charge of their clinic to sign the official or click on the official agreement within the trait system. And I think part of it is Some of it goes to junk mail. Part of it, they don't know what trait is. And even if we tell them, they kind of forget because they're thinking about patients, not about which subcontractor we've hired. So I think we would have a lot more participation if it was a verbal agreement. And really, everything that we're doing has to do with patient data. And no matter where you work, if you work for yourself or you work for a huge agency, you know the rules of patient data. So I would go for the side of having something that a verbal agreement that we can click on as the CPAN team on behalf
I'll
of
weigh in with another suggestion here. Thanks for the presentation, Laura. Is this, yeah, can you hear me? Right, I'll weigh in with a second suggestion, Laura. Thanks for the presentation. The written agreement is a big difficulty for us here at UT Southwestern. But we have a lot of occasions when we need permission to exchange health-related information. And the legal part of our school and our IRB recognize a double verbal consent just as solid as a written as a signature. So this would really involve only two people attesting to the fact that the caller agrees to whatever you're talking about, and that would be really equivalent to a full agreement around health related information. So I think that while a written permission is really the most extensive, it's not necessary for getting the job done of getting solid permission. So, and I think that anything that we can do that helps these offices to call in and get the response that they need with as little work and fuss as possible would really help this program. Thanks a lot.
Sure, Andy.
Thanks. I had to find my mute button. I just want to thank you, Laurel, for raising this, and I know others, share your concerns. I just want to clarify that, when we worked with the Massachusetts program, what they recommended to us was that there be an outreach process and an enrollment process. So that means a conversation between the CPAN provider and the primary care provider that makes sure they understand what we're doing. So there was never any recommendation from them that we do this in writing. It was that we have a process. And so I think being able to do this verbally is fine. And I think, Carol, while I think the double verbal is a great idea, it's also more than necessary. I mean, I think really, to me, the judgment of the CPAN site that they have enrolled the provider should be all that's necessary. And because if you're engaging with the site, then they're enrolled. If they understand what you're doing and you feel that connection is there, they're enrolled. And that's really a subjective assignment. This isn't some sort of, rule or anything else. It's really to try to get a process in place. So it's sort of like, saying, do you have a therapeutic relationship? I mean, it's your decision as the engager if you do or not. And I think these are useful ways to think about how you may want to operationalize that within your site. But I really think it should be up to the individual site to say, okay, yeah, we've enrolled that person. And then I think the mechanisms, Laurel, you laid out are very nice ones for being able to do a workaround for now and then being able to automate that process to make it easier going forward.
Yeah, I would agree. Anything that can get this moving faster, verbal consent would really expedite enrollment. I'd be in support of that.
And one of my staff just mentioned to me in a text that she's watching it on YouTube, I guess. Good employee. So Adrian Hirel had mentioned to me that we're all doing telemedicine now. And with all this telemedicine work we're doing, all the consents are verbal, even in child psychiatry, which is one of the most highly protected areas of medicine.
And I agree as well. And I remember the conversations extensively, Laurel, in the spring when we did have this conversation. And of course, that was pre-COVID. So we certainly are living in different times, and any barriers that we can remove so that we can get our numbers where we would all like them to be would absolutely be a tremendous help to our operational teams.
But can I just clarify, y'all, for the record, like, we're not talking about consent. I mean, I get it that like everything is more liberal now, but this is not consent. These are not patients. There's no PHI. This is enrollment of another practice in a process of consultation. So, I mean, and since it's a public meeting, and for the record, we need to be really careful about the language we're using here. And I mean, these are good points about consent and telehealth, but what we're talking about is enrollment of a CPAN provider, not the consent of a patient. So I just want to make sure we're all super clear about that.
Yes. Thank you, Andy.
Yeah, I agree with Andy. I think quite different between enrolling practices and enrolling patients in terms of the legal implications.
And in mentioning consent, I guess my point was not that this is a consent, but that this is a patient-doctor consent. My point was that even something that usually is much higher level of privacy and confidentiality is verbal now, but then we have this thing that I kind of see as lower in that respect in terms of enrolling people. Just the difference.
No, I appreciate that. I mean, again, from the perspective of Kosh, we want to do what the executive committee wants to do. So if the executive committee is clear that a clinic can say verbally that they want to engage in CPAN, and then we are able to say yes, they've agreed, then I think that we can certainly go there. We just wanted the executive committee to provide us input and guidance.
I'd like to support what Laura just said and maybe even take it as a proposal that the committee could vote on, David.
I guess that's where I was, I think we probably need to go. And I was wondering if we needed any time to write it up, but I think what Laurel said is pretty simple in that, Laurel, what I hear you saying is the ability for a provider to provide verbal consent to work with our CPAN network for guidance for the care of their patients, and that they're able to do that by verbal consent. Is that your motion, Laurel?
Agreement, not consent, agreement that they
agreement. Yeah. That's Andy's question. That they can provide verbal agreement. Yeah. All right, Andy. I'm reading your sign language there, but verbal agreement.
I love Laurel. I love Laurel for making you quit using the word consent in a gentle, therapeutic way.
Yeah, okay. Verbal agreement for a provider to
enroll
with our CPAN. Huh?
Yep, that's it. All right. Well, the good news is that Trade was already working on this process, so it's not like I have to go to Trade and ask for them to work on it. They were.
So say it exactly the way that you want it right now, and then we'll have that will be your motion.
Okay. My motion is that we would like to move to allowing for primary care clinics and teams to verbally agree to enroll in CPAN services.
That is a motion. Do I have a second?
Just quick clarification. Then trait will be modified so that when we do that, we'll get the credit. That the sites will have you'll have the official documentation that that's an enrolled site.
Yes.
Okay. With that, I don't know if I'd call it an amendment. With that understanding, that's good.
Okay. I think, Carol, you had the second there, right?
I'm fine to second it.
Okay. Any other discussion? Okay. And Steve, can you say your amendment again, please?
Oh, just with the amendment that trait will be modified so that this verb to reflect the verbal consent enrolls a PCP in CPAN.
And Andy will, I think, gently tell us that it's agreement, right?
Agreement, right.
Yeah. And so what was put in the consent or in the chat box is the ability to provide for a provider to provide verbal agreement to enroll in CPAN agreement. And trait will be modified to provide information on verbal agreement.
Yes.
Right? So that is the motion by Dr. Williams, seconded by Dr. Tominga, as modified by Dr. Plitzka. Okay. Any further discussion? Okay. Hearing none, I'm going to do a verbal unless somebody objects, and then we will do a formal vote. But all in favor of that motion as I just read it, signify by saying aye.
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 Opposed, nay. Anybody abstain? Hearing no abstain, anybody abstaining or anybody saying nay, we have unanimous consent related to what we just said, related to verbal agreements. All right.
Great, thank you. The next implementation topic had to do with this physician callback within 30 minutes. We have definitely seen an increase from month to month in that metric. So we're moving in the right direction for that. But one of the things that we want to just remind everybody, but it had also to do with the implementation of partly related to trait with how how the system worked. So we corrected that. So that's why we saw some sort of noise with that signal, but we do expect to see that number would change, and it did. So we've gone a 10% increase from month to month, even from last January data, the earlier data. And then the final one was about the call definitions. It kind of came up and a query that there was a term that said missing. We want to clarify for everybody, there are not missed calls. Either a person decides to not finish the call and the call is abandoned before anybody could pick it up, or the call is answered, or the call is gone to voicemail and then returned. So there is not a missed call feature. That is just how sort of, I guess, phone companies look at things, but not how we look at things. So there are no missed calls. So just wanted to make sure everybody kind of heard that, that we are not missing calls. We are definitely calling people back if they need to leave us a message. And then we're just going to switch to the dashboard real quick to show you the dashboard for this, and then we'll move on to T-Chat. I'm mindful of time. So as you can see here, we continue to enroll providers. This particular form on the left, you will see will look very different. In February, Trait was already working on that issue. So that light blue are those clinics that are calling but don't have the final enrollment process done. So we expect that number will change quite a bit with this new sort of process that we've discussed. As you can see, as far as the types of clinics, still the larger percentage of the types of clinics are the pediatric clinics, followed then by family medicine and integrated care. So we are seeing providers across a range, not just pediatricians. So we want to make sure that we continue to do outreach and education to all the primary care physicians in the area. So we're good there. Moving down the screen, what we wanted to really focus on today the most was that there was a very nice uptick, thanks to all of your hard work across the hubs with all the education and the enrollment and engagement that teams are doing. We had a very nice bump in January for the number of calls to the CPAN network across the state. As you can see here, 290. And so that's a nice jump up from December, and is following that trend that we were seeing prior to the Christmas holidays. And then we are still continuing to see a nice array of repeat callers. So again, that idea that once a provider calls once, that looks like they're seeing that there's good utility to the service, so then they call again multiple times. So we're excited to see that information as well, as far as who is calling us. And then finally, as you can see here, the vast majority of people who are calling us are physicians, but it is nice to see that we have physician assistants who are calling, as well as nurse practitioners. We have that yellow one that's for learners. So again, those residents and fellows in their academic institutions. So again, we're seeing a nice variety of providers who are calling us. So go scroll down. The purpose for the calls, as you can see, we have they're calling about specific patients, so they typically are asking to speak on and ask for guidance, very particular about one particular patient. They're also requesting for help with referrals, and 5% of them are about emergencies. So even though we're not an emergency line, we can't handle things emergently. We wanted to check to see how often that might be a question. And then when you look at the change recommendations, this is cumulative, and the calls coming in recommending change, particularly around medications, is about 43% of calls. So again, what we were hoping, expecting physicians primary care physicians are calling and they want to speak to the child psychiatrist because they want to have some help with assessments, with what treatment recommendations are needed, and then specifically when it comes to medical management, how to actually help manage the kid's care safely and appropriately. With the referrals, you could see that about 51% of the time they are asking for help with referrals. And as you can see, the breakdown of the different types of referral requests and what our teams across the state are looking for. Interestingly enough, that 10% of the time they are looking for higher levels of care, but the vast majority of the time they're looking for us to help them find either a local therapist or a psychiatrist to assist them. So just sort of kind of a break there. And then the last bottom, we cannot speak to race and ethnicity because we do not mandate that providers tell us that about people. So that's less than 20% of the time that PCPs are providing that information. So that information about race and ethnicity is not valid at this point. But as you can see here, we have a nice range across the different ages that they're calling about, and that there still is, when it comes to gender, a slight preponderance of girls versus boys, but again, not too far out from what you would expect in just children's mental health. So that's sort of what the dashboard looks like. Just for all executive committee members to know, this is the state metrics. Each HRI will start to get their own individual HRI metrics that they can see, so they can compare themselves to overall state, how the state's doing, and then specifically how their own individual HRI is doing. So that is a feature that's coming in the next few weeks. Okay. So moving on to TCHAT. She's just going to pull the slides up real quick. So the next two slides are really busy slides, and I apologize for that. But we had to really go into the very specific details around definitions, because it will impact both how the data, how the trait is built, as well as how we're going to collect this information so that we can provide it to the state. So we had to be very sort of granular and focused. This tacks on from the conversation we had the last executive committee around the concept that we may at times, on a rare occasions, but at times need to see a young person again for a TCHAT service, and or maybe they need to have their first service extend out by a few sessions because it's hard to find them the next sort of care provider, and it would not make good clinical sense to just stop seeing them. So we had to figure out how to actually operationalize and make those definitions so that as we're building out the platform that we can collect that data as we're seeing the young people. So again, we have defined that we will use the fiscal year for the state, that we will say that a youth is engaged in TCHAT services, they go to at least one appointment, and that an episode of care is defined by that 4-visit process, and that we'll have the ability to start counting that if we need to have that young person have more than one visit in that episode of care, that we're going to have it vary at every visit, a conversation about what we're doing to get them to that next level of care. And then we talked about what to call that next care if the young person needs to come back after they've finished one episode of care. We call it, episode 2, for example, but we'd still track that same young person so they're not looking like a new referral unless the new fiscal year hits, and then that would be considered a new referral. So it was very much in the weeds. We just wanted everybody to see that information. It's the work of the Data Governance Council as well as the state TCHAT team. Next slide. So just wanted everybody in the executive committee to be mindful of that, and that this is sort of how we're envisioning making sure that we're creating the platform appropriately to collect the information in the way that we can then provide good information to both the executive committee and obviously ultimately the state. Okay, we have for services delivery for TCHAT, 11 of the 12 teams are accepting referrals. There's one more team that's working to get MOUs in place, and they are hoping in the next few weeks to be able to do that. We have 2 more joinder agreements that are near completion. Both of them are kind of in phase with their institutions. So I do expect to see them pretty quickly according to their teams. We are working with TRAIT on the implementation build out. And the next 2 slides, I'm not going to go over them in detail, but they do sort of talk about what is the phased implementation that TRAIT will be doing. We are continuing to work on how we can standardize processes across hubs, although we want to continue to allow for each team to manage things regionally, as well as innovate at the regional level as they need to. So it's a balance between what things can be operationalized that we're all going to do the same, and what things just don't work that way because of regional needs. So we want to be working on that. And then the step care model implementation meetings have started with Dr. Storch and Blader. And I know that several teams are working to participate in that step care sort of process that will happen in the next several weeks and months. And again, I'm not going to go over this in detail. It's just for your information at later time. It sort of talks about the deployment timeline for TRAIT. We do expect that at March, we will have this sort of phase, that second phase that we've been discussing, available for all the teams to use as long as they have their joinder agreement signed. Next slide. And these again are just the things that TRAIT will be building into the system to do collection and help with running the programs. This month, we're going to start fresh new semester, new data. Next month, you will see January, February, so we'll start to track month by month. But these are the January metrics alone. We had over 200 schools that sent in referrals. That was about 479 youth that were referred in the month of January alone. Let me be really clear about that. And then of that, 170 of those referrals, by the time we asked for data, had gotten at least 1 appointment seen. So we do expect that some of those numbers will change because sometimes we do have some back and forth between a family before they get their first appointment. And then of those 170, you can see that a good percentage of them needed to have ongoing care even after their TCHAT services were done. When you look at the type of service that each of the HRIs is doing on across the state altogether, about 43% are providing a therapy alone, 9% are providing a mental health with the physician alone, but 32% are doing a combination of both working with the physician and working with therapists. When you look at this, so we are asking for HRIs to sort of help improve the reporting of race and ethnicity. So we don't have data on every single young person that is been referred and has gotten a service. But as you can see, for those that we have that information for, that the 19% are white, Caucasian, non-Hispanic, 25% white, Caucasian, Hispanic, Latino, and then 10% Black, African American, and 1% Asian. So we do hope that by the next time that we have this presentation, that unknown will start to transition into known, and we'll be able to provide you with further data there. And then again, when it comes to male versus female, again, it's about 50-50 split, but also we'll see a tie probably eventually because there are still some that potentially are not providing that to us. And so we hope that we'll see that improve with reporting as we move forward. And then this age for this year, not this year, but this January, again, you can see the breakdown of the ages of the young people that were seen in the TCHAT services. And again, it crosses the spectrum, you know, between elementary, middle, and high school ages. So a nice array of young people are being seen. And like I said, at the next meeting, we will have both January and February data so we can start to compare month to month how the services are going. TCHAT questions, sorry, we had a pausing there for a second. Okay. As I said at the top of the conversation, Jennifer has been working with a lot of different individuals around the sort of WellNeti implementation, including working with the state. As again, we heard Sonia and a talk today about a lot of things that the state is doing. We want to collaborate and coordinate with them and not try to reinvent any wheels. But remember, WellNeti is more of a platform for providers to look at. And the state's goal is to be providers and for families. And so I think there's synergies there. I don't know if Jennifer had anything that she wanted to add about WellNeti specifically.
No, not at this time. Just the next phase for us will be getting everyone's information of the providers that you already have that you refer to. And then WellNeti will start implementing those and putting those in the system. So that'll be the next step. We met as a team, the TCHAT team, and kind of looked at what we want to be able to search by, and that was a successful meeting. And so the next one will be starting to upload that information into WellNeti.
Thank you. Did it in time, Dr. Lakey.
Very good. Any questions for Laurel related to anything that she's talked about? All right, I don't see any hands raised. All right. Well, thank you, Dr. Williams. Lewin, is there anything else that we need to accomplish in this meeting?
Oh.
Any comments or issues that anyone wants to bring up related to the Mental Health Care Consortium before we wind this meeting up?
I have one comment on CPWE.
Yeah.
CPWE is meeting with all the coordinators, the medical directors, as it were, of CPWE at each of the sites. We are all meeting tomorrow, along with Danette has been invited to that meeting, as well as Rishi Swanee from HHSC. And we're going to continue to look at the metrics and other issues. And I foresee that meeting, which will probably occur on an ongoing basis, analogous to the meeting for TCHAT and CPAN, will replace the CPWE work group. And I'll make a formal motion to that effect probably at the next meeting, assuming everybody at the meeting tomorrow agrees to that, because this will become a much more operational meeting whereas the work of the CPWE workforce is pretty much done. Work group is pretty much done.
No, that sounds great. Yeah, thanks, Steve.
Good.
Any other comments?
Just that this is amazing and it's a pleasure and an honor. Thank you guys, everyone who presented, for all you're doing.
Yeah, you guys really are doing amazing work. Looking at CPAN with the number of consults doubling basically month over month from the December, to the work with TCHAT, to the research initiatives that we heard about, and the overall work of the state, and the fellows, again, bringing in 9 new fellows to address the workforce issues for the state is going to be big. So really appreciate everyone working together across our system to really make this happen. And again, really appreciative of the legislature in investing. And I think we're in a pretty good standing, a really good standing in the Senate and the House. We'll get there. And so look forward to the continued work of the consortium. If you have any issues or questions, please don't hesitate to reach out to us. And I'm going to give you back about an hour. And I hope you have a great day. Thanks, everyone.
For your leadership, David. Bye-bye.
Thank you all.
Thank you all.
Thank you all.
Bye.
Thanks.